we switch off. Okay.
Good evening, everyone. We welcome you all to Ortho TV Online. Today we have a webinar on basic hand and wrist surgery in day-to-day practice. So over to the convener, Dr. Amit Verde.
A very good evening to all the respected faculty and viewers. I welcome you all for this webinar of basic hand and wrist surgery. As we all know that in our routine clinical practice, lot of times we are in a dilemma whether what decision we have to take about that patient, about the diagnosis, about the management. And also during surgery, a lot of times we have to choose one method of fixation out of lot of methods available. So to guide on all these things, we have galaxy of surgeons from all over India who are highly experienced and renowned surgeons in the field of hand, wrist and microsurgery. So this is a definitely, this will be a definitely good opportunity to learn from their experiences, and we can ask them questions also. So before we start the program, I will briefly introduce about the faculty. So first, Professor Binu Thomas, sir is Chief of Hand Surgery Department, Hand Surgery Center of Christian Medical College, Vellore, which is one of the renowned center in the world. And he is my teacher also, teacher and mentor. Thank you, sir. Welcome. Dr. Pankaj Ahire, sir is Honorary Secretary of the Indian Society for Surgery of the Hand, and he has keen interest in wrist surgery, and he is attached to Godrej Hospital, Mumbai. And Dr. Rajendra Nehete is not here, but I will briefly tell about him. He is a very good microvascular and hand surgeon, and he is from Nasik only. He will join us in short time. In Dr. Abhijit Wahegaonkar, very renowned and famous personality, and he has traveled across the globe for and visited a lot of hand surgery center, and he is international speaker also at a lot of wrist meetings, and he is attached to Sancheti Hospital, Pune, and Jahangir Hospital. Dr. Shailesh Gupta, sir is a very dedicated and committed hand surgeon, and he trained from Kleinert Institute, USA, and sir is having his own hospital in Indore. Professor Anil Bhatt, sir is Associated Dean of Kasturba Medical College, Manipal, and he's a very dedicated surgeon and a very good academician. Dr. Praveen Bharadwaj, sir is senior hand surgeon at Ganga Hospital, Coimbatore, and he is very workaholic and academic person, and he is my teacher also. Dr. Parag Lad, very well-trained surgeon and presently working in Thane. He is attached to Jupiter Hospital, and he is having his own setup, Pinnacle Ortho Care at Thane. And Dr. Amit Vyas, sir is very well-trained surgeon, and he is from Pink City, Jaipur. He is attached to Fortis Hospital, Jaipur. Dr. Bipin Gangurde, he is also a very dedicated hand surgeon and having special interest in congenital hand differences and attached to Wadia Hospital, Mumbai. I welcome you all, sir. And without wasting time, I will proceed towards our today's webinar of basic hand and wrist surgery. Our aim is to keep all these things very basic so that all the clinical practicing orthopedic surgeons and residents also can learn about hand and wrist surgery. So today's webinar, we have a session on wrist and also a session on fractures of the phalanges and some pre-recorded videos also. So first, I will invite Dr. Praveen Bharadwaj to talk on radial nerve palsy associated with humerus fracture. Over to you, sir. Please share your screen.
Good evening, everyone.
I'll be talking on this very commonly encountered problem in orthopedic practice, that is a radial nerve palsy in association with humerus shaft fracture. I'm sure every orthopedic surgeon would have faced this challenge, that there is a humerus fracture and patient has a radial nerve palsy of such kind. Radial nerve palsy is actually one of the most disabling of all the nerve palsies in the upper limb. It is more disabling functionally than the
Sir,
median and
please share your
cervical
screen.
palsy.
Praveen sir, your screen is
Yeah.
not shared.
Yeah. Is it seen now? I shared, I thought.
Yeah. Just now you are sure we can see
Okay,
this.
okay.
So this is, I think, second slide. Now this is first slide. Okay.
Yeah,
So,
okay.
yeah, please
So
start.
let me start on.
Yeah, please start.
So I'm sure all the orthopedic surgeons would have surely faced this kind of problem where there is a radial nerve palsy association with humerus fracture. It can be quite a taxing problem for a surgeon, especially if he has done the plating and the patient has a radial nerve palsy post-operatively. And it is quite a tension situation for the patient as well and for the surgeon also. Patients usually are much more disabled than what they are after ulnar and radial nerve palsy because a dropped wrist has a decrease in grip strength of 70%. So the hand becomes so weak that they are not able to use for any activities. And if the paralysis has happened after the surgery, the patients are very, very concerned and they make the surgeon also very tense because they want to really know when the recovery is going to happen, whether you have to do a re-operation or whether they should wait and watch. Now, it is quite obvious for us to go to the literature to try to find out what is the solution for this problem if one is encountering such, but it is quite confusing because many of the papers would say you do exploration immediately, whereas others would say that we need to wait for some time. The most challenging is a closed radial nerve palsy associated humerus fracture, but most of the general consensus is on to wait for spontaneous improvement because it is well known that almost 80% of these fractures associated radial palsy do recover with time. So though there is a lot of literature which deals with this concept, but I found that the most authoritative the conclusion comes from this paper by Bishop and Ring, where they have analyzed all the literature based on the recovery pattern of the radial nerve associated with humerus fracture. And interestingly, they found that there is no right answer for all the patients. But they suggested that a patient who is not having very high demand means their activities, the regular job does not require very fine finger activities. They could as well do equally good with a tendon transfer. But if the patient's activities or profession requires fine activities, then they are the candidates for doing the nerve surgery. But overall, there is no single answer to this because the energy of the trauma, the fracture pattern, severity of injury all differ. And moreover, there is a lot of difference in the patient recovery pattern of each nerve and also the surgeon's belief in the nerve repair. So basically, we can have 5 different situations in which the radial nerve is injured along with a humerus fracture. And let us see each one by one. An open humerus fracture is with a primary radial nerve palsy is no-brainer because here the radial nerve can be seen as injured. And this is a point in which all should repair the radial nerve. One important point in such situations is we should always explore the radial nerve before the plating and see if it is approximating well. If we feel that there is a slight gap at the nerve, there can be some shortening can be done at the humerus so that you get an end-to-end repair, which will give a much better result. If the gap is quite big, then depending on if the patient is suitable for a good nerve recovery, we can put a graft. Otherwise, if the graft length is more than 5 centimeters, it is better to go straight away for tendon transfers. When you have a closed humerus fracture with primary radial nerve palsy, and if it is planned for conservative treatment, we generally observe for 3 months and then do an EMG for the brachioradialis. If there is no recovery in that, then we start thinking about nerve exploration. If fixation is planned, it is better to have a look at the radial nerve, especially if the injury is a high velocity injury. If the nerve is contused, it should be left as such. If it is frayed, not severely crushed, it can be left as such. But if it is totally splayed out, it is better to excise that part and put a graft in. So this is one of the patients who had a very high velocity injury with associated multiple injuries and deep abrasions over the arm. And when the radius plating was planned, we also explored the radial nerve. We can see it was a complete, almost complete transection, and we freshened the edges and the repair. And this is the kind of result you get at 8 months. Radial nerve being predominantly a motor nerve, there is less cross innervation, and we get a very nice result, good perfect motor recovery in about 8 to 9 months. And this is the kind of result you can get. And over a period of time, we will not even realize that he has any deficit at all. Now, when the patient is coming at 3 to 4 months treated elsewhere, you are really not knowing what has been the condition of the nerve. We can talk to the surgeon sometimes, but if the surgeon is very concerned that he has not seen the nerve or he feels that nerve could have got damaged, then it is better to explore. But whenever you are doing a delayed nerve exploration, most of the times you will require a graft. So one need to be very well prepared before itself, and patient should know that if the graft is required, the chances of improvement could be lesser, and he will require the graft from the lower limbs. But we generally try to see what is the patient's occupation and demands. So if the patient occupation and demands require very fine independent finger movements, we venture into the nerve exploration. Otherwise, we try to move them towards the tendon transfer. So this one patient who presented at 1 month, very concerned that recovery is not happening, what will happen? We told we wait. And at 3 months, the Percutaneous started working, and at 5 months, the wrist extension came, and over a period of 6 months, he completely recovered. So it is a good strategy to talk to patient, reassure them that things are going to better with time. And we let them observe for about 4 to 6 months. But if we know that there is no recovery in 3 months at all, then it is better to explore, considering that patient is desiring an independent finger movements and their profession requires that kind of activities. On exploration, you will find this kind of picture. Almost always will require a graft, but graft also gives quite reasonably good result, and this is the 9-month follow-up of this patient. You can see he has got a good wrist extension, and finger and thumb extension also recovered quite well. However, we need to caution the patient always that the recovery after nerve graft may not be perfect. So this patient, we have done a nerve graft, he recovered good amount of wrist extension, but his thumb extension didn't recover, and which required a tendon transfer. So whenever there is a closed humerus fracture with secondary radial nerve palsy, we almost always observe. But if the patient has undergone an IM nailing, radial nerve is not visualized, it is better to explore. Now, why we are more towards observing and giving a tendon transfer option? Because the tendon transfer results for radial nerve palsy are quite good. And usually at 6 months, if the recovery is not there, we'll straight away go for tendon transfer. You can see a function of this kind, which actually looks as if you can do all the normal activities. And the patients usually can go on to their normal activities in about 6 months of time. Now, when you see a good result of tendon transfer like this, it is quite exciting. And you can see even the person who was first to do a radial nerve tendon transfer, he felt like there is no incurable radial nerve palsy. The results are quite amazing. So at times it comes in our mind whether it is worth repairing the nerve or we can straight away go for tendon transfer. Yes, it is worth repairing the nerve because this kind of independent finger movements you cannot get with the tendon transfer, and the nerve repair is the only way to get this. So if the patient activities demand this sort of function, we should always go for nerve repair. However, it is at the cost of uncertainty. Over a period of time, it is going to recover. And patients who desire early improvement, who are not perfect candidates for nerve recovery, and if the surgeon is not very comfortable with nerve repair, the tendon repair is quite good. And these are two different ways of getting an almost equally good result. Thank you very much.
Thank you. Thank you, Praveen sir, for the excellent presentation. there are some questions. In case of operated case of humerus fracture with radial nerve palsy, if patient is
Yeah.
presenting to you after 1 month, when will you advise the EMG and nerve conduction study?
Yeah. So if the patient is presenting at 1 month, actually we will not do any nerve conduction study at that time. Though a nerve conduction study at 6 weeks would show what is happening in the radial nerve. But in a patient of that kind, you know that with your examination that radial nerve is injured. We know that the wrist drop is there, so we don't have to diagnose radial nerve palsy by doing an EMG. So we would rather ask the patient to wait for 3 months, 4 months, and then do the EMG and nerve conduction study. Here, the nerve conduction study and EMG is not to diagnose the problem. It is mainly at 4 months, we want to do EMG for the brachyradial list to know whether there is any early recovery or no, which will guide us whether we should explore or wait for some more time. We don't do the nerve conduction studies for diagnosing a radial nerve palsy because it is quite obvious with the wrist drop.
Okay, thank you, sir. There is one more question. What are your thoughts about the role of ultrasonography in cases of radial nerve palsy, closed?
Yeah, high frequency ultrasound is a good addition these days. And the radiologists are with the ultrasound probe, they are able to trace the radial nerve and they are able to tell whether what is the condition of the radial. It is almost like a MRI these days with the high frequency ultrasound. But still, I think they are able to very well delineate if there is a complete transection of the nerve. But in humerus fracture associated radial nerve palsy, the complete transections are quite uncommon. It will be a contusion or a fraying of the nerve, which still they are not able to tell that convincingly. So ultrasound is useful if they are able to locate it and give us some information. But I think when it comes to radial nerve palsy, the diagnosis is quite obvious. We want to know whether it is going to recover or not. And that we will come to know with time and EMG at 3 to 4 months only.
Okay. So there is one more question. How are the results of nerve grafting for radial nerve palsy?
Yeah. So nerve grafting results are actually quite nice when you consider the nerve grafting in general. So radial nerve, whenever you do a nerve graft, the main problem is because of that missing segment, the mismatching of the fascicles could happen. But in radial nerve, since it is predominantly a motor nerve, so that much of mismatching will not happen. And even if you have done some mismatching, the motor recovery will happen because all of them are motor fascicles. So if you ask a percentage, I think even a graft of 5 centimeter would have a success rate of 80%. 90% for wrist extension and 80% for finger and thumb extension.
Okay. So after, so one more question from the viewer. After doing radial nerve repair, is there any role of tendon transfer?
Yeah. So this is also a very nice question and very good that somebody has brought it out. It is a common practice to do what is called as internal splinting. So there are recommendations that you do an internal splinting so that, especially for the wrist. So pronator teres is transferred to ECRB at the same time while doing the nerve repair. So this is thought that if you do internal splinting, then the patient wrist extension comes and that will improve their grip strength. They need not wear the splint. But if you ask me personally, it is not a good idea to do that because it is not required. So when you do a pronator teres to ECRB transfer, you will put a cast for 1 month and splint for another 1 month. So 2 months of splinting is anyway required. And when you've done a repair of radial nerve, in 4 months or 5 months, the wrist extension is going to recover because that is the first branch from the radial nerve is the ECRB branch. So just for 2 months of avoiding the splint, you need not do an extra surgery, removing the pronator teres and transferring to ECRB. In fact, it has been proved that once pronator teres is transferred to ECRB, the pronation force reduces. So it is useful when it is required, but when it is not useful, it is not required. And for wrist extension, which has got a probability of recovering 90% in just 4 or 5 months, we never do an internal splinting.
Thank you, sir. One more last question.
Yeah, and about this, we should not do internal splinting for finger and thumb. It is
Okay.
only for the wrist. Because for finger and thumb, you are going to use a wrist flexor. So that is much more important muscle. So you should not do, if somebody is doing, you should do only for wrist, but we don't do it and it is not required.
So one last question, for such cases of radial nerve palsy, which type of splint you will advise?
So this is also a very important aspect because a lot of patients, when they come to the OPD, they will have a dynamic splint. So the dynamic splint is the one which is going to the fingertip. It is bringing the fingers into extension and wrist to extension. But actually, if we put a splint which is going till the finger, which is very bulky, the patient is not able to use the hand. One of the main purpose for putting the splint is, so when you put a splint to the wrist, so decrease in grip strength is because the wrist is bent down. So once you stabilize the wrist, the grip strength improves and patient is able to use the hand. So we should always advise only wrist splint. Finger should be left free for the patient to use. So a dynamic splint till the fingers is actually not required. Just a wrist cock-up splint with fingers free should be sufficient.
Okay. Thank you, Praveen, sir, for
Thank you
excellent
very
talk
much.
and nice explanation. So
Thank
now
you.
I will invite Dr. Bipin Gangurde for his talk on importance of X-ray in hand and wrist.
Can you see my screen?
Yeah. Thank you. We can see your screen. Please go ahead.
Okay. So whenever we think about diagnosis, always ask for all the views. Now, if you see this this picture of the prince, he is abusing someone. However, if you take a proper AP view, he is asking someone something. So these are the importance of AP and lateral views. So what are the types of views we need to take into consideration? So the type of views we need to take into consideration are PA view, AP view, lateral view, and oblique views, which are all special views. So how do we take a PA view of the wrist? It is a zero rotation view of the wrist. The shoulder should be abducted up to 90 degrees and it should be parallel to the ground. The elbow should be flexed to 90 degrees. So how do we realize that this is an AP PA view? Is from the styloid process of the ulna. So styloid process is on the ulnar side. This means that this is a true PA view of the wrist. Also, the distance between the carpal bones is less than 2 mm, and always look for the Gilula's lines. So in this case, you see the Gilula's line in the proximal part of the scaphoid, lunate, and the tracheotomy. Then the second Gilula's line is along the distal part of the scaphoid, lunate, and the tracheotomy. And the third Gilula's line is along the capitate and the hamate. So these all things should be looked in a proper PA view. AP views are also important. So AP views normally we take to look into the Gilula's lines. And also you note that if it is an AP view, the styloid process of the ulna is little bit radially. Zero rotation lateral view of the wrist. This is another important view which is needed to be taken for the wrist. So shoulder should be adducted like in this picture, and elbow should be flexed to 90 degrees. Now in this view, we locate the DRUJ, position of the carpus, and for the carpal injuries. Note that the position of the pisiform is very important in case of a true lateral view of the wrist. So what happens in a true lateral view is, according to this paper by Goldfarb in 2001, he says that the ventral cortex of the pisiform board should be between the ventral cortex of the distal pole of the scaphoid and the head of the capitate. So in this case, these three views are acceptable views. However, these two views down here are unacceptable views. So this is the true lateral view of the wrist. Now there are again, so this is a case which suggests there is some abnormality in the carpal bones and there is a fracture of the radius. So what you see normally, which is significant, is the fracture of the radius, and you go and plate it and you forget the other things. So look at the Gilula's line. The Gilula's line are broken and the capitate is inverted. Always take a lateral view in all cases. In lateral view, again, you see that the DRUJ is subluxated. So this is a Galeazzi type of fracture, and the capitate is inverted. So, and also there is a scaphoid fracture. So this is a case of scaphocapitate syndrome. Again, there is some disruption in the Gilula's lines, but this might be, if there was only a PA view available here, you might just forget it. Again, now if you see the lateral view, you see that there is a perilunate dislocation. Again, on the X-rays PA view, you see what is called as the like the avascular necrosis of the scaphoid bone. So this was confirmed with MRI later on, but you have to suspect these diseases of the carpal bones. Also, the diseases of the lunate and other things like Kienbock disease can also be found out on PA views. So now this is the red lateral view of the wrist. This is mainly for the distal and radius fractures. So you have to tilt the wrist to about 11 degrees, and you see the standard lateral projection here down, and what do you look here is the lunate fossa and the teardrop. Also, you have to look for the projection here, which is the radius, the radius. The AP view, so the PA view of the wrist and the lateral view of the wrist. Always look for the radial inclination, radial shortening, and the volar tilt in case of lateral view. And here you can see the teardrop and the teardrop angle. If you have done a surgery in the lateral view, you have to look for these signs as according to the Song's criteria. So this is the critical line. So if the plate is projecting across the critical line, that means that you can irritate the flexor tendons. So this is in an acceptable position. However, this X-ray and another X-ray, I have to look for the flexor or FPL tenosynovitis. And if the patient is having tenosynovitis, I will have to remove the plate early. So always look for this projection in the lateral view, and look if it crosses this projection, that means you have crossed the watershed line, and there might be a irritation of the flexor tendon. So oblique views are very important for the wrist and the hand. So hand rests on the ulnar border and it tilts to about 45 degrees in a volar direction. The scaphoid, triquetrum, body of the hamate, scaphotriquetral, and the trapezium trapezoid joints can be seen properly in this view. Fourth and fifth CMC joint also can be seen in this view. Ulnar deviated views are very important to note the complete anatomy of the scaphoid. So ulnar deviated view in 20 degree of ulnar deviation is a scaphoid view. However, always give a little bit of extension to the wrist. So this may help in improve visualization of the scaphoid. So this is called as a PA ulnar deviation view of the wrist. So these are the X-rays which are needed for a scaphoid series. This is a PA view. You can see that the bone graft here, there is a bone graft here. However, there is no union seen properly. This is the scaphoid view with 30 degrees of extension. Now in this case, you can see the entire anatomy of the scaphoid, and there are signs of union. Pronated view, you can see the entire length of the scaphoid, and the lateral view to note if there is any humpback deformity or any other problem with the scaphoid. Clenched fist views are special views which are needed mainly for scapholunate dissociations. Always compare clenched fist view with the opposite side. A scapholunate interval greater than 4 mm, as in this case here, can be a suggestion of a scapholunate instability. Also note that there is a signet ring sign of the scaphoid. So this is a foreshortened scaphoid because of the hyperflexion of the scaphoid in a scapholunate dissociation. If there are hook of hamate fractures, mostly in bicycle, those who ride bicycles get this type of fractures, or on injury on the ulnar side of the palm. So in this case, the hand is maximally extended and volar surface of the wrist rests on the cassette. The central beam is directed towards the palm at 15 degrees. So this is a very important view to note the hamate. So this is the hamate and this is the pisiform. Supine, oblique, and the ball catcher's view. These are two important views which can be interchanged actually. So ball catcher's view is the two it is like a position of catching a ball. So in this view, this is a type of supine oblique view only. You see mainly what is called as a pisotriquetral areas and compare it with both the sides. So you can see if there is any pisotriquetral arthritis. So this similar type of view when you take for a single hand. So in this view, you can see the head of the metacarpal and head of the metacarpal, and it is used for pisiform pisotriquetral arthritis and metacarpophalangeal joint. So these are the views which are mainly used for metacarpal fractures, are prone oblique views, PA views, and a supine oblique view. Specialized view for metacarpal head subtle fractures is a Brewerton's view. In this case, the palm is flexed at 60 degrees and an X-ray beam is passed through the metacarpophalangeal joints. You see this type of view, and it is mainly used for the subtle fractures of the metacarpal head. Metacarpophalangeal joint arthritis also can be found out on these X-rays. Lateral view of the thumb and the CMC joint can be made by making hand pronated to 20 degrees and thumb flat on the cassette. So in this case, you can see the lateral view of the thumb, and the CMC joint arthritis can be visible very clearly in the lateral view of the thumb. PA view of the hands and finger, the hand is fully pronated and digits slightly separated. So single digits also can be found out. Single digit X-rays can also be taken by this type of view. So if you see this X-ray, you can see that there is a tuft fracture. This is a single digit of the digit X-ray of the hand. In this X-ray, there is something abnormal in the PIP joint. However, you need to confirm it with a lateral view. So lateral views are necessary in all the finger fractures or any finger condition. So this is a true lateral view. So this is the way you take a true lateral view. The hand is in lateral position, and thumb side of the thumb side up for third and fourth digit, and thumb side is down in case of second digit. This is not a true lateral view, which we usually get in our clinical practice, and the patients come with these type of X-rays. If you note these two X-rays, you can see that there is a fracture here. However, when you take a true lateral view, you find that there is a fracture dislocation of the PIP joint. Oblique views of fingers are also important to find the position of the fragment and the injured area. So in this case, you can see there is a subtle fracture in a true lateral view. Prone oblique and supine oblique views are done to note that where is the fracture. So you can see that there is a fracture on the radial side. Again, there is a fracture on the radial side here. So finger views, again, PA view, oblique view, and a true lateral view is very important to note the exact anatomy and the type of fracture. This is a type of Mallet fracture. This Mallet fracture. So you need to know, you find it only on true lateral view. So to conclude, scaphoid series, we take PA view, scaphoid view, prone oblique view, and lateral views. Carpal bones can be found, carpal bone abnormalities can be found by PA, AP, true lateral, prone oblique, and supine oblique position. Distal radius fractures can be very well found out by PA view, tilted lateral views. Metacarpal views are like PA view, supine oblique views, which focus on the metacarpophalangeal joint, and a prone oblique view. Pisotriquetral arthritis can be found by a ball catcher's view. Subtle metacarpal head fractures by Brewerton views. And thumb and CMC joint views can be found by the Roberts view and the lateral view. Finger, all PA and lateral are very important. However, oblique views are also important to mark the fragment position. Thank you.
Thank you, Bipin. It was a very nice presentation, highlighting the importance of lateral view. There are some questions. You can stop your screen sharing.
Yeah.
In case of, have you stopped it?
Hello.
Yeah, stop screen sharing.
I have not stopped it.
Yeah, you have already. Amit, he has stopped sharing his screen. Yeah.
Yeah, okay.
Yeah.
So the question is, in case of fracture lower end of radius with scaphoid fracture, how will you order the X-ray?
So in case of fracture lower end of radius and scaphoid fracture, yeah, we have to take a PA view, a scaphoid view, a prone oblique view, a tilted lateral view of the distal end of the radius. So these are the X-rays which are necessary, and also the scaphoid series, prone oblique X-rays are necessary.
Okay. So sometimes we have to take lateral view of multiple fingers. So
Yes.
how will you advise to do that?
So if you want to take lateral view of the multiple fingers, I think true lateral views are very important. So in that case, I will go for a separate X-rays of each digit. So if there are multiple finger fractures, better to take separate X-rays of. You can take oblique fan type views, which we normally get. The fan type views, however, they tell us where the fracture is, but they will not demonstrate the proper anatomy of the fracture. So that is why we need to, for our management, we need to take a true lateral views of separate fingers each.
Okay. Okay. Thank you, Bipin.
Thank you.
That was an excellent talk. So now we'll move to our next session, wrist session. Now I will invite Dr. Pankaj Ahire to moderate the session. Over to you, Pankaj sir.
Thank you, Amit. Good evening, everyone. I have the pleasure of inviting my dear friend and the most famous W in India. You know what I mean. America gave us a lot of W's. The Windows, the Walt Disney, the Warren Buffett for our living generation. Europe gave us Windows. Europe gave us Windsor and Wimbledon. India has given us Vayagaonkar. So we are privileged to have you here, Dr. W. Over to you for scaphoid non-union.
Thank you very
diagnosis
much.
And management.
To say I'm humbled would be an understatement. Thank you very much, Amit, for putting this webinar together. Thank you, Pankaj, for the introduction and the opportunity to speak here. My task is to speak on scaphoid non-union, and this is an extremely common problem that we will encounter in clinical practice, and something that is a dilemma for a lot of people. So it is generally defined as a failure of healing by about 6 to 12 months from injury. And Joe Dias, in his seminal work on scaphoid, in one of his publications, he observed that it is difficult to determine union, and it is usually unreliable if the injury is less than 3 months at presentation. The usual presentation at around 6 to 12 months when the scaphoid is not united would be deemed as a non-union. And scaphoid non-unions have this defined and demonstrated predisposition to progress towards arthritic changes of the wrist joint. And this has been very well described by in the study of Mack and Gelberman. And this is called as a snack wrist. And a missed scaphoid non-union or an untreated non-union can have very debilitating outcomes, and thus this importance of recognizing and dealing with this appropriately. So briefly, the objectives of the talk would be to understand the basic anatomy and the pathomechanics and some classifications, and based on these classifications, what are the treatment recommendations for the management of scaphoid non-union. We will try to understand the techniques in the management of non-union, and very briefly understand what snack wrist is and what the options for this entity are. So here's a case example. This is a 17-year-old young student who is a semi-professional football player, and he injured his wrist about 4 months ago, but we think it was a little earlier than that. And at that time, he presented to another hospital with complaints of pain, especially on strenuous work and activity. And this pain was alleviated on rest. and he had pain in the wrist, and splinting was advised. And he continued to have pain, and he presented to us about at 6 months, and he had these presentation findings. And the initial X-ray, we looked at the initial X-ray, and we didn't think much was going on in the first X-ray, although we felt that there was something going on here, very not clear. And then after about 4 months, when he came to our clinic, we got this ulnar deviation, radial deviation view, where we found that there was something definitely going on at the proximal pole of the scaphoid. So what next? We obviously would go on with imaging, and what are the options that we resort to? Computed tomography, CT scans, MRIs, and bone scans are usually recommended, of which CT scan is perhaps very sensitive and very appropriate for such presentations. And this is the clinical picture on the CT scan. And then these are the coronal and the sagittal images, again, demonstrating the non-union and the bone resorption at the fracture site. So these first few slides with the case example pretty much are the most common case scenario that you would encounter in clinical practice. And this is more often than not the process in diagnosing scaphoid non-union. Once you've diagnosed scaphoid non-union, what are the treatment considerations? And you may grossly classify them as those related to the fracture of the bone itself. And these are the location of the non-union, the classification, the duration since injury, whether there is a gap or pseudoarthrosis with resorption of the bone, whether there is a DC deformity, the vascularity of the fragment or the non-union, especially in relation to a proximal pole non-union, whether there are any arthritic changes already set in, and if there are any associated injury, for example, an untreated or a missed transscaphoid perilunate dissociation or dislocation, or maybe a scapholunate injury that may be associated with a scaphoid non-union. Patient factors are usually those of the age of the patient, the dominance, the demands, comorbidities, as well as smoking. And then surgeon factors obviously also play a very important role in my opinion. And these are related to the training of the surgeon, the choice of the implant, more often than not, the availability of proper implants, bone graft choice, and so on and so forth. So all of these will perhaps have some kind of an impact in the outcomes when you're dealing with these fractures. So way back in 1966, Barton observed that the scaphoid is an awkward but important little bone. And we all know that this is a boat-shaped bone, and that's where it derives its name from. And the anatomy of the scaphoid is not alien to a lot of us. Suffice it to say that it is a very peculiar bone in saying that it is an obliquely oriented bone, and then it crosses both carpal rows. And it is a very important part of the proximal carpal row, where it is attached by the scapholunate ligament to the lunate, and the very important scaphotrapezial and the scaphocapitate ligaments, which kind of are important in maintaining the kinetics and the kinematics of the wrist joint. And this is important. We'll see that in a few slides about when we talk about the DC deformity that is associated with scaphoid non-unions. Anatomy is again very well described. I will not belabor too much on this, but this is an important slide. And Richard Gelberman, in his seminal work, again, has studied the vascularity of the scaphoid in great detail. And there are usually two blood vessels that will supply, one through the waist, which supplies the proximal pole, the distal pole and the waist, whereas the proximal pole is relatively avascular as compared to the distal pole and the waist. And this is because the nutrient vessels will kind of go forward and give a reverse branch to the scaphoid, and therefore this part of the scaphoid is relatively avascular, and this is something which is very important to take into account. And then those of you who are oriented to understanding why femoral neck fractures are more prone to AVN, we can draw analogies from femoral neck fractures in saying that there is a tenuous blood supply. It's an intracapsular fracture. The scaphoid lies within the joint completely, and therefore it is akin to being an intracapsular fracture. There is no true periosteum. The fracture configuration, that is to say a very oblique fracture line for that matter, will render it to be unstable and prone to non-union, and then there are high torque forces at the fracture site. The mechanism is usually due to a fall in an outstretched hand. This is again something that all of us are very familiar with, usually seen in males and those who are involved in sports and outdoor activities. And we have to recognize that perhaps the most important preventable cause of scaphoid non-union is failure to recognize the fracture at the get-go. So please keep in mind this particular point. There is an inadequate initial treatment at times, an improper assessment of the bone healing. So all of these are perhaps the most common yet preventable causes of non-union. And of course, delayed treatment or inadequate treatment a lot of times. And this is simply because fresh fractures may not be evident on initial x-rays. And therefore, it is perhaps better to err on the side of over-treating these fractures than otherwise. Physical examination of a patient presenting with non-union will usually be that of restriction of movements and pain on strenuous work. These are the criteria that Javad Parvizi, who is now very famous for hip surgery, hip and knee, way back in 1998, he said that tenderness in the snuff box, tenderness of the tubercle, and pain on axial compression have 100% sensitivity for diagnosing scaphoid fractures. I'm talking about fresh fractures here. However, the irony is that most of the scaphoid non-unions may not be painful, and that is where the catch is. So we need to have a very high index of suspicion when you have these patients coming to the clinic. Imaging, Bipin has very nicely elaborated the imaging modalities and the views that are used, but I would like to draw your attention to this particular view, which is the true lateral view of the scaphoid and not the lateral view of the wrist, and this is the ulnar oblique view. So you can see here the scaphoid is in complete profile. So this is the long axis of the scaphoid in the lateral view, and this is the lateral view of the scaphoid. So it is an oblique of the wrist, but a lateral view of the scaphoid. And in this particular view, you can also look at any humpback deformity or flexion of the fracture fragments or the intrascaphoid angle. Radial and ulnar deviation extends the scaphoid, whereas radial deviation will flex the scaphoid in an otherwise intact wrist. But if there are any changes in the scaphoid morphology or anatomy in these views, you would suspect something going on. The DC deformity is usually because of foreshortening of the scaphoid, because of flexion, and it simply means that the dorsal cornu of the lunate is now tilted up, and this is called as a DC deformity. We won't belabor too much on this because this is outside the scope of the talk, but suffice it to say that a scapholunate angle of greater than 60 degrees would indicate a DC deformity. We usually resort to additional modalities of treatment in the form of a CT or an MRI or at times both. And a CT scan is usually a good idea to assess the union of the bony architecture, to understand the bony union status, whereas the MRI can give you more information about the soft tissue and vascularity status. There are classifications that have been described. Green's classifications grades them from grade 1 to 6. And there is a classification that has been described by Herbert from D1 to D4. And he takes into account whether there is a fibrous union without a deformity, a pseudarthrosis with early deformity at the top here, a sclerotic pseudarthrosis with an advanced deformity, and a full-blown avascular necrosis with a fragmented proximal pole. Jean-Vallon from France also has classified them very simplistically as fibrous, cystic, sclerotic, and avascular non-unions. And you can see in these particular pictures the different types of non-unions that may come across. But suffice it to say, if you look at this particular slide, it's very easy to understand that fractures involving the tubercle or the distal pole or maybe up to the waist, we may always proceed to union. However, if there is an obliquity of the waist, which is very oblique, this is where the analogy to the neck fractures, neck femur fractures comes into play, or a very proximal pole fractures. Now we know from the hypovascular proximal pole, these are the fractures which will usually proceed to non-union. a very succinct algorithm for scaphoid fracture non-union management. If there is a delayed union, you usually just put in a screw to provide rigidity or stability, and this will usually progress to union. If there is an established non-union with a fibrous non-union at the waist, you may perhaps do an open repair with or without bone grafting. And if there is a sclerotic non-union of the waist, you may use a wedge graft. If there is a humpback non-union, again a wedge graft. And if there is a proximal pole non-union, you may use a vascularized bone graft. This is again an elaboration of the earlier slide. Again, I won't belabor too much on this. But in summary, if we were to look at the treatment options, they will be more or less classified into these few types. So they are percutaneous or open reduction and internal fixation to stabilize a fibrous non-union, or an open reduction internal fixation with a bone graft, a pedicle bone graft or a free vascularized bone graft to restore vascularity if there is an AVN, or more recently, the arthroscopy assisted reduction internal fixation with bone graft. This is the classic technique of Rusi and Matteucci technique, where you take a reverse hockey-shaped incision over the FCR extending to the thenar eminence. You open the FCR subsheath, you retract the FCR, and then on the capsule, you may make either a longitudinal or maybe a zigzag incision like this to elevate the flaps. The scaphoid non-union is exposed, it's curated and cleared. The gap is measured, and in that gap, you would put in a bone graft to restore the length of the scaphoid, thereby correcting the DC deformity. And then you may want to fix it either with K-wires or a screw or whatever is available. You have to take care that the screw is of adequate length and does not over project in the radiocarpal joint. And this is a schematic diagram to show how the DC deformity is corrected, or is basically is present because of scaphoid foreshortening. So it is important that you restore the length of the scaphoid by putting in a graft, and then you correct the DC deformity. What about vascularized bone grafts? You may use this is the knee joint, this is where the leg is, this is where the thigh is, sorry, the hip is, and this is where the leg is. And then you take a medial femoral condyle graft from the based on the descending genicular artery here, and then you can take a graft from the medial femoral condyle and do a free vascularized pedicle bone graft. Or you may use something called as a 1-2 ICSRA, which is ICSRA, which is a bone graft based on a reverse flow in this particular pedicle here, and then you harvest a bone graft and you flip it to the scaphoid to plug in the non-union side. Arthroscopic assisted bone grafting is also something that is evolving and is a neat adjunct in the armamentarium of the wrist or the hand surgeon. This is a classic example of a scaphoid non-union with bone resorption. And this is a video demonstrating how we do this particular bone grafting in a standard arthroscopic setup. We harvest the bone graft either from the radial styloid or from the iliac crest. Our preference is iliac crest. And then we morselize this bone graft, and then you put in this bone graft through this small cannula. This is a hypodermic needle cannula that you can just use to introduce a bone graft inside the non-union side. You may also use a small suction tip cannula with trocars, or maybe even the burr, or maybe even a small dura separator, and pack in the bone graft at the non-union side. And then once that's done, when there is adequate filling up. So this is the capitate for your reference. This is the proximal pole of the scaphoid. This is the distal pole up there. And this is the non-union site here. And then we fill this non-union site with morselized bone graft. And then you put in a screw with the percutaneous technique. I think that's the next video. So I won't belabor too much on this, but ultimately this is what you get. You can see the small portals, just 1 and 2 portals here. And then you have passed your screw from volar aspect in a retrograde manner. And then this procedure is done in a minimally invasive method. The same can also be applied to a proximal pole non-union, as you can see in this particular case. And then because this was too small for a screw to hold the fragment, we use K wires, and at 6 months, it has gone on to unite, as you can see in this particular case. So what is the fate of failed bone grafts? If your index surgery for non-union fails, the second surgery has a very high, almost a 60% rate of failure. So you have to get your first surgery correct. Now, very brief and very passing mention about the snack wrist. This is when a scaphoid non-union goes unnoticed or untreated, and then you start developing these arthritic changes because of the non-union. The capitate is trying to push its way down, and then there are increased point contact pressures between the scaphoid and the radial styloid here. It begins with arthritic changes and peaking of the radius, then it goes to the scaphoid fossa, then it goes on progresses to the mid-carpal joint, and then there is span arthritis. There are salvage procedures that you then have to resort to when you're faced with a snack wrist, and these are usually excision of the distal pole of the scaphoid, radial styloidectomy, a slack procedure, and modifications such as a proximal row carpectomy, wrist denervation, limited carpal fusions, wrist arthrodesis, or a total wrist replacement, which, however, this option is unfortunately not available with us yet. So in conclusion, this is a very commonly missed diagnosis of a very common injury. We all know that this natural history leans towards development of arthritis and can be very debilitating. Missed diagnosis and inadequate or improper treatment is the most common preventable cause of scaphoid non-union. And I always tell my residents and fellows that it is better to make mistake on the side of over-treating rather than under-treating. And all is not lost even if non-union occurs. Accurate diagnosis and appropriate treatment can yet be applied to salvage the non-union. With that, I thank you for your attention, and I'll be happy to take any questions that you may have. Thank you.
Abhijit, I will put a certain question to you from the viewers. Yeah. Till that time, Dr. Amit can get his video ready. Yeah. I'll just put all the questions into one and ask you, how long would you observe how long would you wait to save non-union scaphoid before you say, no, this needs to go for salvage? So is time a criteria in deciding treatment of non-union in terms of saving the scaphoid, or going for a salvage procedure? And in doing so, does vascularity of the scaphoid also play a role? Do you do any investigation to check for vascularity? And does vascularity decide on whether you are going to salvage or save, and what type of graft you are going to use?
So I think all of us will concede that there is no easy or simple answer for this, for these set of questions. But let me just try to kind of give my take on it, and correct me if I'm wrong or if you have any inputs. So first and foremost, as far as the time is concerned, I think as long as only the radial styloid corner is affected and there is no gross arthritic change in the radiocarpal joint, especially the the involvement of the cartilage of the scaphoid or the involvement of the cartilage of the scaphoid fossa. So I'm talking about snack 1 wrist. I think we are still good to try and salvage the scaphoid. With the advent of arthroscopy, I think this has become a little easier. So before we even commit ourselves to a big arthrotomy and a big procedure, or keeping all options open, just a very quick diagnostic round of arthroscopy would give you a fair idea about the status of the cartilage. Now, as far as the vascularity is concerned, we all know that an MRI is a very fallacious and a very kind of misleading kind of an investigation. It is very difficult to say, based on an MRI image alone, if the fragment of the proximal pole is avascular or not. So I think perhaps most authors or most surgeons would agree that the visualization of punctate bleeding when you let go of the tourniquet after you're done a debridement and removal of all the necrotic tissue is maybe the best indicator that we have so far as the vascularity of the pole is concerned. This can also be done arthroscopically now. So you debride with fine shavers or maybe even fine curettes, manual, kind of curettage, and you let go of the tourniquet, and you can see the bleeding from the fracture fragments, and that is a fair indicator of vascularity. Now, again, there are people, there's a school of thought that argues that whether on a PCO, I remember very distinctly saying that even in an avascular proximal pole, he just goes ahead and bone grafts, and he believes they go on to union. So we still need a lot of evidence to kind of establish this for a fact. There is no clear-cut kind of an answer, and the jury is still out there. So I hope that answers the question. I'm not sure.
I'm sure no amount of time is sufficient to answer all the questions on scaphoid, and certainly not the one on vascularity.
True.
So thanks, Abhijit. That was wonderful.
Thank you. Thank you very much.
Now it's my pleasure to invite Dr. Amit Warade to speak to us on percutaneous fixation of the scaphoid. I think it is one of the necessary skills that we need to develop, is to get a wire in the scaphoid in the desired direction. I think it is a skill which is appears much easier than it. I think it takes years to get a good scaphoid wire in very few attempts without causing much damage to the scaphoid. So Amit will tell us the key points in fixation of scaphoid by percutaneous screw fixation. Herbert screw being just one of the options that we have.
Yeah. Thank you, Pankaj sir. Dr. Abhijit has made my job easy by explaining very well the anatomy of the scaphoid. So this patient presented after 8 days after the injury, and he had fracture at the junction of the waist and proximal pole. So we decided to fix it with the Herbert screw. So headless compression screw, the better word is. So this should be the proper position in the operation theater. Surgeon should be sitting on the hand side of the patient, and monitor should be on the opposite side. And next is we have to extend the wrist and deviate it on ulnar side. And before doing any surgical procedure, we should very well know what instruments are available for the surgery. We should also check whether we have all the screw sizes available or not. So next, we mark on AP and lateral planes. So we confirm this under C-arm, and this will give us an idea for putting guide wire in the scaphoid. So once we have done with this thing, we use this 16 number needle for passing guide wire. This can be act as in sleeve. This is a very good device. So good thing is we can see that needle under C-arm also. So after putting the needle onto the distal pole of the scaphoid, you just see in the C-arm, we have to direct it along the long axis of the scaphoid, and at the same time we have to elevate our hand a bit, because scaphoid is like a twisted cashew and it is in 3 planes. So once we confirm the position, we have to pass guide wire. After putting guide wire, we should check the position of guide wire in three planes: AP plane, pronated oblique view, and lateral view. So this is pronated oblique view, and this is lateral view. So wire is inside the scaphoid. So after this, we gently remove the needle, and now we have to measure the size of the screw required for fixation. So here I have increased the incision a bit, and now we are using this direct measuring device. We have to pass it on the guide wire. And see here, the reading is around 31 mm. One thing we should always remember, we have to subtract 2 mm from the actual length, because this is the length. There is 1 mm compression at the fracture site, and 1 mm screw can go inside at the head region. So I generally do this after measuring the screw length. I put guide wire in the distal radius, because lot of times while drilling the wire came out, and it is very, very difficult again to put the wire into the same hole. So now this is the drill bit. This is a 2 mm drill bit. We have to drill it slowly, and after that, next is to pass a headless compression screw. And this is the specialized screwdriver they give with this set. There are 3 marking at the top: green, yellow, and red. I will explain about this. Now it is at the green mark. It means that the sleeve is engaged into the head of the screw, and our screw is slowly going inside. And one thing I forgot to tell you, once we put the guide wire in the radius, we have to keep the same position of the wrist, otherwise guide wire will break. Then also it is a very difficult situation. We have to open the wrist to remove that guide wire. So now we are crossing the fracture site. So now here we can see yellow mark. It means that the top of the screw has reached up to the, it's flush with the distal end of the scaphoid. So as we drive the screw inside, now we can see that fracture side is getting reduced nicely and compression is there. So at this stage, if we see on the screwdriver, we can see a red mark. It means that screw is totally inside the bone. This is what I was talking. So after this, we gently remove the screwdriver and guide wire. After that, we have to confirm it in all the views again before we finish the surgery. Now, this is a AP view, and this is a pronated oblique view. Screw is very well inside, and lateral view. If we see the incision, it is a very small incision. Here, we don't have to take stitch also. It will heal automatically on its own. And we give a thumb spica splint. Thank you very much.
Thank you, Amit. There are no questions currently, but I have certain comments to make. Sometimes when we are presenting edited videos of a surgical procedure, some important steps may be misunderstood, or there may be some skipping of some important steps. So since there are a couple of thousand of surgeons who are seeing this video, I'll just put down my observations.
Yeah. Okay.
One, though the title of the talk said it's a Herbert screw, the screw that was used in the demonstration is the headless compression screw. These are various companies making various screws. It is extremely important that you understand the design and the principle of each screw from the manufacturer. That's point number one. Point number 2, when you are using the HCS, the two screws which are shown to be used in a single step. Perhaps it is a matter of editing that might give a wrong impression. So we need to use the outer sleeve with the screw as a separate screwdriver to insert the screw, and then the slender screwdriver which inserts into the outer sleeve is to be used for engaging the screw. That's the second observation. Third, the actual length of the wire when measured from end to end in the scaphoid and the screw, the recommended reduction is 6 millimeters to account for 2 millimeter away from the distal pole, 2 millimeter compression at the fracture site, and 2 millimeter sinking of the screw. So these are the three observations which I made, which I thought should be shared for benefit of the audience. Currently, there are no questions for you, Amit. We will come back to you if there are any questions on this particular talk. Now it's my pleasure to invite my good friend, Professor Dr. Anil Bhatt from Kasturba Medical College, Manipal. How not to miss carpal instabilities. The talk itself should explain that it is one of the very frequently missed injuries, even by seasoned upper limb surgeons. So, Anil, over to you.
Am I audible?
Perfect.
Yeah. Thanks, Amit, for this, and also Pankaj for the invite. Now, as Pankaj said, how not to miss carpal instability. I mean, that's a very often missed kind of injuries, and we always feel bad that somebody missed it. And in the next few minutes, I would probably give some tips as to how not to miss this. Now, if you look at this, the wrist itself in terms of the anatomy of the wrist here, so you see that there are so many ligaments, and if there are injuries to any of these ligaments which are interlinking these small carpal bones like this, and probably it will be all scattered in like a string of pearls, and that's what happens, and that is the basic idea of carpal instability. Now, very classically, if you look at the history of this patient, these are young patients most of the times, but then they would come with the history with the fall usually 1 or 2 months later, because most of the time the injuries are missed, or it's sometimes treated as a small sprain and sent off. And generally, most of these would complain of radial sided pain, and they would have these kind of x-rays. Now, anybody would definitely miss these injuries if you look at this complete jumbled up anatomy of the wrist. It's very complex anatomy what you see here, and that is why it is missed. And I would come to tell you why this is so much more complex. So the possibilities in a radial sided pain, all of us know, could be a distal radius related injuries. It could be scaphoid fractures, or one of the things which is commonly missed is the scapholunate, and this is the harbinger of carpal instability, the scapholunate injury. A good clinical examination is paramount for these things. And as I said, the scapholunate is the area which is the most common carpal instability pattern we see, and that's where the whole instability starts most of the times. The injury patterns can be different in some patients, but this is the commonest one. So to understand instability and not to miss them, what should we do? We need to know how normal wrist x-rays look, which Bipin has already told. And so we need to take the standard x-rays, which is the PA for the wrist and not the AP, and then lateral and the oblique views. So this is the thing which the patient came with, actually with this x-ray. But actually, as Bipin showed, that the normal PA view looks like the standard PA view looks like this. So you can see now the carpal bones are arranged much more nicely, and it's not easy to miss any of these injuries compared to this X-ray here. So that is the importance of taking an appropriate X-ray. And again, all these has been alluded earlier. You need to check all these, the concentricity of this arcs here. So any mismatch you see here definitely means there is something going on there. Now, in the lateral view, Bipin spoke about the SPC lateral, where the pisiform is here, SPC lateral, the capitate is here, which is a true lateral view. But also you need to check this. the angle between the scaphoid and the lunate. The lunate should be sitting right here in the neutral position, and the normal angle is about 30 to 60 degrees. So to understand carpal instability, this is one of the main key findings we need to remember. The other thing is to also know the normal shape of the lunate. If you see the normal shape of the lunate is almost a trapezoid kind of a thing. And if you have a patient who comes with this and then it doesn't look normal to you, and then something is happening there, which means the shape is changed. It's more towards a triangular shape, means the lunate is tilted either dorsal or roller, it might be subluxated. Now, so the same patient came to me, the first thing I would do is to change this X-ray, right? So from an AP, we need to take the right X-ray, which is the PA view. And if you carefully look at the lateral view now, you would see that this lunate is tilted slightly dorsally there, and that scapholunate angle is definitely increased. Now, if somebody would come like this, I don't think anybody would miss the carpal instability. This is a static instability. None of us should miss this, the gap, because again, in a normal X-ray, all these gaps should be equal. It's about 2 millimeter, 1 to 2 millimeter. That's the cartilage thickness there, and it should be equal. And anything increased means again you need to have a suspicion, and this is definitely much wider compared to any of these. So it means there is definitely a problem. So nobody will miss this, but what people will miss is something which is more dynamic and which is not being seen. So if your clinical examination points to a scapholunate pathology and X-ray is normal, the second point is you have to bring out the dynamic instability as much as possible, or you need to image further, which is usually an MRI. The more easier thing is to bring out a dynamic instability, which means that you need to stress that, try to recreate or provocate the injury by what is called as a clench grip use. So this is the exact way to take the clench grip use or the clench fist use, and then you would have to always compare. We always do both PA and AP. Sometimes it is seen better in AP actually, but then you would see the difference of this. So this is where you are trying to getting into the dynamic part of the instability, which means that if the capitate, if there was an injury here, the capitate will try to push this when you stress this and the gap increases. So this is the dynamic scaphoid instability which we talk of. Now, the lunate goes with a stronger person. Now, if there is an injury somewhere here between the scaphoid and the lunate, or the scaphoid is fractured like what Abhijit was talking, the lunate will now move with the triquetrum, which has got a tendency to extend, which means that's why the lunate will go with the. So if you have a scapholunate injury like this, the lunate will now go with the triquetrum and the scapholunate angle will increase here. And that is your classical DC deformity. So the lunate is dorsally tilted in the intercalated segment, which is this here. And it is there's an instability. So if you look again, this is the normal way the wrist goes from radial to ulnar deviation, right? From to ulnar deviation. So you see the scaphoid extending so nicely here in ulnar deviation, and then this whole complex will push the scaphoid here to flex here as it goes to the ulnar deviation. Now, if you see this, can you see this now? So here the gap is increasing here, which means there is a problem here, very commonly associated with distal radius fractures. So don't look at always the distal radius, always look at one joint above here and then see this. So if you have scapholunate injuries, isolated injuries, then they require reduction, pinning, or repair. And if you have commonly associated distal radius fractures, you have to treat the distal radius fracture, and of course you have to treat this. So you need to keep the lunates in the neutral position, whichever way. So generally we pass a radial lunate wire and try to keep it in the neutral position like this, and then try to pin this down here along with the scaphoid here. So this is one of the commonest way of doing the reduction. And if you want to keep the scaphoid extended, you would pass another wire here between the scaphocapitate and then remove this radial lunate wire here like that. And at the end of your surgery, they need to move together. So that gap should disappear here, and they need to move nicely like this. And here again, the scaphoid should be in the neutral position like this. So this is the simplest way of treating like this scapholunate ligament injuries. Now, it can be that it's not always scapholunate, it can be lunato-triquetral. And once that happens, now the lunate is now moving with the scaphoid, which means it's got the tendency, normal tendency to flex, which means you see a lunate which is flexed on the palmar side. So this is the VC kind of deformity where the scapholunate angle becomes less than 30 degrees. So the DC and VC, we always used to hate this terminologies, but it's a very simple concept that it's an intercalated segmental instability. The intercalated segment is basically the proximal row bones linked to each other by the ligaments, and the dorsal or volar in the DC or VC refers to the direction which the lunate will take. And both the DC and BC involve proximal rows and are ligamentous predominantly. So it's called as carpal instability dissociation. So there is a dissociation there in the intercalated segment. And lunate is the key bone there for this in the proximal row. Now, the fourth concept you need to understand, where we should not miss the carpal instability, is how the force will now progress. So this is a very nice cadaveric dissection, this article, if you read, where a cadaveric study where the injury starts on the radial side and prolongs to the ulnar side. Now, there are many mechanisms involved, which can be their ulnar side mechanisms are also involved, or it can go through the bones, or it can go through the lunate, or it can go below this also. But this is the commonest way the injury progresses in a wrist injury. Now, here is another patient with high energy trauma, hyperextension injury, painful swollen wrist. And again, so the same checklist which I told. Now, if you see the lunate, it looks triangle. It's not looking trapezoid. The hilus arcs are damaged, right? And then the capitate is not there on the lunate here. So capitate has gone dorsal to the lunate. If you draw the axis here, which means that there is everything around the lunate is probably injured. So this is what is called the lesser arc injuries, where the force now goes along the ligaments here and then goes out. So here all the ligaments are damaged, the scapholunate, the lunator-triquetral, and connections between the capitolunate here. So everything around the lunate dislocates dorsal or volar. So perilunate dislocation is not an isolated injury, but it's actually a stage in progressive carpal destabilization. These injuries are missed initially because, as I said, or I showed, the complex anatomy of the wrist itself. And accurate interpretation of radiographs is the key. There's another case where you now see again the lunate is looking triangle there, the Gillila's arcs are damaged, and you see a fracture there. So this is the same thing which has happened here. The capitate is dorsal here. Very rarely there are volar lunate, perilunate dislocations also. So what has happened is there is a fracture there. So means the force has gone now through the bones and not just through the ligaments. So these are called as greater arc injuries, which are perilunate dislocation and fracture. For example, we call it as a trans-scaphoid perilunate dislocation. So you know what is perilunate? The word trans is used to any fracture going through a particular bone. It could be trans-scaphoid or it could be trans-capitate, any of these things. And it can be dorsal or volar dislocations. Now, the basic principle of management of this is appropriate X-ray, as we said, and then a traction view is sometimes helps us with this, and sometimes definitely a CT scan will tell you where the anatomy is. Close reduction and cast is one option, but most of the time we go for close reduction and percutaneous spinning. The best would be open reduction, internal fixation, and ligament repair. So this is one way of doing a close reduction, the Tavernier's method, where you hyperextend the wrist, increase the deformity, and try to get that capitate back into the lunate there. Technique of percutaneous, as I said, again, keep the lunate in the neutral position, try to fix the scaphoid, okay, and then try to pin down the lunate on all sides. So you have a scapholunate wire coming here from the lunator-triquetral here, and scaphocapitate wire here. So the lunate should be in the neutral position, and we try to fix all the bones around it with these wires like this. So if you want to do open reduction, so it is a classical dorsal perilunate kind of a dislocation. And if you see this, you need to open it up with a classical approach to the wrist joint. And once you open it up, what you actually see is the capitate. You don't see lunate here because the capitate is dorsally dislocated here. And if you gently give some traction there, then you will start seeing the lunate somewhere hidden below. So this was dorsally dislocated. The lunate is more in the volar side now. Sometimes you see these kind of injuries, the chondral damages here in the capitate here, and they could be the reasons for future stiffness and arthritis. And once you do that, we gently try to reduce this capitate back, and then you get the wrist movements. And then you need to come and check exactly what's happened to the ligaments. So if you check this, there is a damage here. There's a lunator coming in, fracture. There's the LT ligament which is damaged. So these are the ones which require so that fracture, that is a scapholunate here, ligament here, and this is the LT ligament here. So this scaphoid needs to be fixed here. The LT has to be repaired, and then the lunate has to be reduced nicely back into this position. And sometimes you might have to go on the volar side also. Sometimes if it's very difficult to reduce from the dorsal side, so always be ready to increase your incisions on both dorsal and volar if the reduction doesn't come. And once you do that, you do the repairs, you do the fracture fixation of the scaphoid, You do the repair of the ligaments here, okay, and suture back the capsule nicely there. And at the end, this it should be that the whole thing has to move in a nice way. That's very, very important. So that's the now. There could be another situation again with a very painful swollen wrist, but patient also has some tingling and numbness in the hand. That is the history, and you see an X-ray like this, you know that the lunate is completely out now and is probably compressing the median nerve. So it's actually a spectrum. So you have a perilunate kind of dislocation, then this sometimes if the injury goes on, this lunate can get subluxated, and finally it can dislocate. So perilunate to lunate dislocation is a complete kind of spectrum you see. And the same thing happens here where the dorsal ligaments are damaged, then the radiolunate ligaments also get damaged. So you have these short radiolunate and long radiolunate ligaments here, and that gets damaged, and finally the lunate dislocates, which is classically called as a spill teacup sign here. As I said, the median nerve can be compressed. The median nerve is being tented here by the lunate here, and just if you retract the nerve, you will see that the lunate is right there. So you might have to start with an ulnar incision and try to reduce this and relieve the compression of the median nerve here, and then go back dorsally and do the same thing and repair the ligaments. So what's the prognosis? Most cases are still frequently missed at presentation. It results in a chronic wrist dysfunction, degenerative arthritis finally. Delay in treatment influences long-term outcome, but open reduction is still worthwhile. Even if they come about 1 to 2 months late, it's still worthwhile to do an open reduction. Late repairs generally require both dorsal and palmar approaches. Many reconstructions or options are available if they come late, and if reduction cannot be accomplished, or if there is significant cartilage damage, either a proximal row carpectomy or partial wrist fusions is probably indicated as a salvage procedure. Thank you so much.
Thanks, Anil. Just a question. One question. When you do a close reduction and you get a good close reduction, just because you got a close reduction, is that a reason enough not to do an open reduction of the ligaments and do percutaneous spinning? Or in that, if not, what are your criteria? In which cases would you simply put wires across the scaphoid and the lunate and the lunate and the triquetrum? And in which cases you would actually want to repair the ligaments?
Yeah. So once you do a close reduction, and see that the success of close reduction is based on how soon the patient comes to you and how soon the edema sets in this, and then it becomes a little difficult. If they're coming in early and you recognize this and you get away with a close reduction, a lot of times it happens because the wrist is so unstable. And then what I do is basically check and screen on the C-arm and see how they are behaving. Okay, I want that synchronized movements in all directions. Radial to ulnar deviation, palmar flexion, dorsiflexion. At any point of time, I feel it's very unstable, right? I would try to go for an open reduction most of the times and try to repair the ligament. That is the best way to do. Now, if you don't do that, then obviously the second option is to just pin it and hold it and hoping that it will heal. So that is most of us, we do, even with the distal radius, with the TFCC kind of injury, we pin the DRUJ hoping that it will heal, right? The literature now says that open reduction and ligament repair would be the best option. Now, if a patient has come immediately within a day, within few hours, I think the pinning is still a prudent way of doing it because the injury is really fresh and the ligaments have high chance of healing. Okay. So that is what I would do. But if the patient has come probably about 48 hours later, I would go, my decision would be more towards an open reduction and ligament repair.
Oh, okay. Thanks, Anil. I'm sure there will be a few questions for you as time goes, and we'll come back to you. Amit Warade will now speak to us about Kienbock's disease. As all of us would be aware that Kienbock's disease is far more prevalent than what literature has been quoting, 1 in 10,000. I think all of us sit on this webinar will vouch that it is perhaps more frequent than 1 in 10,000. So Amit will tell us about how to make decisions in management of Kienbock's disease.
Okay, thank you, Pankaj sir. Kienbock's, this is also a very common problem in our routine clinical practice, and patients come at a very different stages of the disease, and sometimes we have a dilemma. What treatment options should we go for? So we'll try to solve this. Avian of the lunate was first described in 1843 by Pest, And Robert Kienbock was a radiologist who described changes associated with lunatomalacia. Generally, when these patients present to us, they present with wrist pain, stiffness, and significant decrease in grip strength. And there may or may not be history of trauma, but some patients correlate these things with the trauma. And on examination, there is swelling and tenderness on dorsal central part of the wrist. It may mostly due to synovitis. And diagnosis is mainly by X-rays. So Professor Lichman has classified this condition into 4 stages. In stage 1, X-ray will be normal, but changes can be picked up only on MRI. In stage 2, there will be sclerosis of the lunate, but lunate architecture is well maintained. There may or may not be fractures associated with this. Stage 3 is a stage of fragmentation and collapse. In this stage, in stage 3A, there will not be collapse, but in stage 3B, there is proximal migration of the capitate. And due to this, radioscaphoid angle increases. We'll see this later on. And last stage is the stage 4, where there is mid-carpal joint arthritis. So X-ray, this is a very important tool for this condition particularly, for diagnosis of this condition and staging of the condition, number 1. Second, we have to see DRUJ variance, whether there is a neutral ulnar variance, negative ulnar variance, or positive ulnar variance, because our treatment depends on all these things. Role of MRI is it is a very good tool and very sensitive tool for picking up the vascular changes of the lunate. And CT scan role is very limited, particularly in some cases of stage 3B, when we have to see associated fractures and all. So most important question, do we have to treat all Kienbock patients? So the answer is yes, because the disease progresses. But yes, we have to keep a watch clinically also. And management is basically according to stages of the Lichman's classification. So the main principles in the management are revascularization of the necrotic lunate and unloading of the lunate, and some salvage procedures when the lunate is not reconstructable. So when the patient presented to us in stage 1, we give conservative treatment with cast and splint for 3 months. But even after giving this treatment for 3 months, patient do not have any symptomatic relief. And if there is radiological progression of the disease, then we should consider lunate unloading and revascularization. Stage 2 and stage 3A of the Kienbock disease, here goal is revascularization of the lunate and unloading of the lunate. So for revascularization, the procedures available are vascularized bone grafting and core decompression of the distal radius, and a lot of other procedures, but I am not mentioning it due to lack of time. So next we have to see status of the ulnar variance, whether there is a negative ulnar variance or neutral and positive ulnar variance. In case of negative ulnar variance, we can do joint leveling procedures such as radial shortening osteotomy and ulnar lengthening. A word about radial shortening osteotomy, 2 to 3 mm is considered as optimal shortening. And if we do more shortening, then patient may complain of pain on ulnar side of the wrist. So this gentleman had a stage 2 of the Kienbock disease. So here we did radial shortening, and it produces the load on lunate by 70%, and range of movement is not affected since it is an extra articular procedure. We generally do this osteotomy at the diaphysis region, and we put 3 screws distally and 3 screws proximally. Though there are a lot of procedures described such as osteotomy at the metaphyseal level also. So the same patient, 1.5 year follow-up, osteotomy site has healed nicely, and this patient had a very symptomatic good relief. Another procedure for this group of patients is vascularized bone graft. So this is the example of 4-5 extensor compartmental artery vascularized bone graft. So here we can see that this is the lunate, this is the distal radius, and we take graft from distal radius. And this is the fourth extensor compartmental artery. This is fifth extensor compartmental artery. And this is a combined pedicle. And we have to put this bone graft into the lunate. And proximally, we have to ligate the anterior introosseous artery. So there are some papers who say that if we combine this procedure, then we get good results. So generally, we combine the procedure. So this, we'll see this example. This patient had a stage 3A of the Kienbock's disease. So for this patient, we considered both combined procedure, vascularized bone grafting with 4-5 extensor compartmental artery graft and joint leveling by radial shortening osteotomy. So here, this is, I was saying, this is the graph from the lower end of radius, and this is 4th ACA, this is 5th ACA, and this is a combined pedicle, and this is the lunate. It was curated on the dorsal side, and here we have to put this graft. And in the same patient, we did radial shortening also by doing osteotomy, and the same patient 2-year follow-up. The osteotomy site has healed nicely, and he has got reasonably good range of movement at the wrist joint. He is totally symptom-free and gone back to his original work. Now we see patients of stage 2 and stage 3A when there is a neutral and positive ulnar variance. So in such cases, we can do capitate shortening osteotomy. There is enough evidence to suggest that after this osteotomy, there is revascularization of the lunate. But though personally, I don't have any experience of this procedure. So now moving forward, when we come to stage 3, we have to differentiate between stage 3A and stage 3B. So here we have to see the radioscaphoid angle. So what happens in the Kienbock's disease, there is proximal migration of the capitate, and due to this, the scaphoid goes into flexion. And due to all these things, the radioscaphoid angle is increased. So here we can see in AP view, this is called as cortical ring sign, which we can see on AP view of the X-ray. So if we see this, then certainly the patient is having stage 3B problem. So now in this stage, our goal is stabilization of the carpus, preventing further collapse, and decrease the load across the radiolunate joint. The available options are we can do proximal row carpectomy and limited carpal fusions, such as STT arthrodesis and scaphocapitate arthrodesis. So according to the evidence available, after doing scaphocapitate arthrodesis and STT arthrodesis, there is significant loss of range of movement. And the studies say that the result of proximal row carpectomy are better than the limited carpal fusion. And it is a simple procedure also. So we routinely do this procedure only. So we'll see by example, this patient had stage 3B Kienbock disease. And for this, we did proximal row carpectomy. This is a procedure where we remove scaphoid, lunate, and triquetrum of the patient, and the head of the capitate articulate with the lunate fossa of the radius. And dorsally, we have to repair the radiocarpal ligaments. And the same patient, she has got a reasonably good range of movement and pain-free, no symptoms. And stage 4, we left with only option of wrist arthrodesis. So our protocol is for stage 1, we go with conservative treatment, and for stage 2 and stage 3A, when there is ulna minus, we do vascularized bone grafting and radial shortening. And when there is ulna plus, I will certainly consider doing capitate shortening osteotomy along with vascularized bone graft. And in stage 3B, proximal row carpectomy, and in stage 4, wrist arthrodesis. Thank you very much.
Thank you, Amit. That was very precise and crisp. This is more or less what most of us do, except perhaps many of us may not have a large enough experience with capitate shortening. I think this is the protocol more or less that we follow. Only thing I would add is the role of arthroscopy is increasing more and more in planning of treatment of Kienbock's disease. If there are any questions that come from the viewers, I will put it to you. It's now my pleasure to invite my dear friend, Dr. Shailesh Gupta, to talk to us about thumb CMC arthritis, diagnosis, and more about management. Shailesh, over to you. Shailesh, your audio is off.
Okay, I'm sorry. Okay, thank you, Pankaj and Amit. Thanks, everyone. So it is one of the most common, just a minute. It is one of the most common cause of the radial-sided wrist pain, especially in the elderly age group population. And we see in the middle age group person also. They commonly present with the pain, weakness of the pinch, and deformity. As you can see, there is some prominence at the CMC joint along with the tenderness. And when you do the mobility test, there is a grinding sensation which indicates a wearing of the cartilage, and the two ends of the bone are touching and grinding each other. So, and followed by there is a decrease in the pinch strength, as well as a decrease in the range of motion because of secondary development of the fibrosis along the arthritic joint. So how do you do that? How do you manage this type of patients? So the most important thing along with the clinical symptomatology, way of presentation, is to diagnose what is going on is the radiology. As Vipin has pointed out the importance of the various views, here the Robert view is very, very important. When you do a hyperpronation view, you can see the CMC joint very nicely over here. You can see that this joint is subluxating. Besides the standardized view, which is AP and lateral, which shows the arthritic changes in the joint. Having a CMC joint Roberts view is very important in actually classifying the stage of disease. You can see the joint is subluxating out. Then another view is a stress view. You put the stress on both the MP joint and apply lateral pressure on each side, and you can see the joint is little bit subluxating over here on the left hand side. So how do you do the staging? Well, in stage 1, the articular contour is normal. The XY absolutely look normal. There may be a joint subluxation like this, or there may be a joint space widening because of secondary synovitis and increase in the fluid in the joint. And what we see in the stage 2 is that there is a slight narrowing of the joint. There may or may not be sclerosis, and the joint debris, that is osteophytes and secondary bone formation, are usually less than 2 millimeter size. When you have a further higher staging, the joint debris increase in the size more than 2 millimeter. And to differentiate with the stage 4, you have to see what is going on with the ST joint. The scaphoid trapezoid joint is looking normal. These all views, you can assess this thing in the Roberts view. So again, the radiology is very important. And what you find in the stage 4, that is a pantrapezial arthritis. There is a arthritis above and below the trapezium. You see there is a narrowing of the joint space between scaphoid and the trapezium, and there is a complete loss of the joint space between the first metacarpal and the trapezium. So having classified the disease, what would you do with the patient? Of course, a non-operative treatment is essentially we tried in the form of splints. You can give the NSAID, which reduces the inflammation of the joint, and you can put the joint local steroid injection in the joint. Swigart, in his study, found that 3 weeks of the full-time splintage plus 3 weeks of the weaning period of splintage usually give 76 and 75% reduction in the symptoms, so that the patient defer the surgery in a stage 3 and stage 4 of the CMC joint. So a non-operative treatment is worth trying before offering any surgery, irrespective of your radiological classification of the disease. What other else think? You have to have an activity modification. This is just a funny example of activity modification. There are various ways, like you are a housewife, you can increase the thickness of the knife handle. You are writing with the pen, you can increase the thickness of a pen by, or you can have a thicker pen so that the lot of pressure is not borne on the CMC joint and your grip becomes much relaxed. So having said that, if all the conservative trial fails, like local steroid injection, activity modification, splintage, all this fails and the patient continue to have a problem with the pain, not able to do the activity of daily living, the surgical management comes to the next. So it all depends what surgery you are offering. It depends upon the demand of the hand, what is the occupation, what is the age, and how is the going to use the hand in the future. Of course, the staging of disease is the foremost important thing in offering any treatment. Simultaneously, in the clinical examination, whenever you are doing the surgery, just look for the MP joint collapse deformity. The MP joint has not gone into the hyperextension. Having said that, if you just correct the CMC joint problem and not looked at the MP joint deformity, a surgical correction is going to shift your problem from CMC joint to the MP joint, and patient will never be happy for his surgical outcome. This is an example of stage 1 and at least stage 2. This is the X-ray we have shown over here. There is a joint is subluxated. Patient is quite young, and he's an officer, and he's not able to, not exactly not able to write, but he was having a lot of problem in writing and doing the office work. So when we assess the thing, there is an instability. There is no history of trauma. These are the patients who are early precursor for development of the CMC joint arthritis. So FCR ligament reconstruction of the instability was done in this patient. Another example of the same, who is in the subluxation of the joint at the age of 40 years, come with the CMC joint pain with no history of trauma, no other inflammatory disorders. So these are the patients who are in the stage 1 and probably can be taken care by the ligamentous stabilization procedure. This is a clinical assessment of the patient who have a subluxation of the joint, painful joint, no history of trauma, and having a pain of chronic duration. And they have a difficulty in fine motor activity because of the pain. These are the patients who are in stage 1, can be treated by ligamentous reconstruction. It's one of the example of a girl who had a similar type of situation and had a bilateral ligamentous reconstruction. You can see there is a hole for the FCR ligamentous reconstruction, and these are the movements she is having post-op. And of course, no pain. She came for the pain management. There is no pain. The movement was normal since the beginning. So what you do in the stage 2, late stage 2 and 3, young physiological age, high demand hand, isolated CMC joint orthodesis is the treatment of the choice in the heavy manual laborer. Having said that, LRTI, I will come to it later on, is also a good choice. This is one example who is a farmer by occupation, having a type, I would say late stage 2 arthritis, had a fusion of the CMC joint. And what are the contraindication for the fusion? Again, I said that pantrapezial arthritis should not be there. So it's not there in the stage 2. The bone stock should not be poor. And profession requiring the fine movement of the thumb should not be offered orthodesis surgery. When you have a low demand of the hand who requires movement, middle age group, I would consider ligamentous reconstruction, tendon interposition, orthoplasty. And in elderly age group, you can straightforward do a simple trapeziectomy, LRTI. However, there are different methodology of treatment is also available. I will come to it in later of this part of the lecture. When you have a stage 4, that is CMC and STT arthritis, you can just do a simple trapeziectomy. You can do a LRTI also. You can do a mini tightrope. Mini tightrope is what? You excise the trapezium, then you suspend by minimal incision procedure to the first metacarpal to the second metacarpal in appropriate tension, so the problem of subsidence doesn't occur. This is a follow-up of a lady who had a LRTI about 5 years back, and now you see there is a good joint formation between the first metacarpal and the scaphoid. There is no arthritic changes and no pain over here. This is one of the example who is a post office clerk having a bilateral, because he has to lift the files every day, large amount of files every day, is a bilateral CMC joint arthritis. You can see there is a complete loss of the joint space, and he has a bilateral excision of the trapezium, simple trapezium excision, and you can see the follow-up. The left hand side is around 7-year-old follow-up. I think it had done in 2013, and the right hand side is a 5-year-old follow-up. You can see the grip strength. But simultaneously you see there is a laxity of the first CMC joint. So a patient who is more concerned about the laxity, which is not of clinical significance, I may offer the LRT. I have to do the counseling with the patient. Your pain will go away, but you will see some abnormal mobility at the base. So what is going on world over? Initial treatment started with the simple trapeziectomy. People find it out that the laxity is not good. We can offer a better treatment. Then the LRTI come into the procedure. Then because of later subsidence, which was again of no clinical significance, joint replacement, partial trapeziectomy, allograft, etc. comes into the procedure. But we are circling in the same, we are running in the same circle. We started with the simple trapeziectomy, we went to the LRTI, then realized simple trapeziectomy is a really good answer. Then from LRTI, we got to the joint replacement, again coming back to the simple trapeziectomy. So what is more? The less is more in this type of cases. So what is the evidence? It's published in Journal of Hand Surgery. 5 to 18-year follow-up for the treatment of trapeziometacarpal arthritis, a prospective comparison of excision, tendon interposition, and ligamentous reconstruction and tendon interposition. What was the conclusion? Just look at this 3 line. The outcome of all the 3 variants of trapeziectomy were similar after a minimal follow-up of 5 years. There appears to be no benefit of tendon interposition and ligamentous reconstruction in a longer term. Remember the term, in a longer term, but the certain procedure has an advantage in a shorter period of time. Like if you want to have early rehabilitation, LRTI is superior than the just doing a trapeziectomy, and adding a tightrope again becomes an early rehabilitation advantage. What are the complications with the surgery? There are injury to the superficial sensory nerve, which is possible, iatrogenic metacarpal base fracture, graft excursion, late MP joint collapse with the pain, proximal thumb metacarpal subsidence with painful instability, and dorsal CMC joint subluxation with pain, which we commonly see in a simple trapeziectomy, but I have not seen any recurrence of pain by doing only simple trapeziectomy. Thank you very much for your patience listening.
Thanks, Shailesh. We'll just take 2 questions, one for Shailesh and one for Amit. Shailesh, question for you is, if you have a grade 2 or a grade 3 stage 2 or a stage 3 CMC arthritis, which has gotten better with supportive treatment, would you ever consider surgery for them, despite them being reasonably asymptomatic?
Yeah, the treatment is again based on the symptom, not the radiology. So the treatment will not be any surgical treatment will not be offered if they are symptomatically better with the conservative line of treatment.
Fine. Thanks, Shailesh. Amit, question for you is, you mentioned PRC in the treatment of Kienbock's disease. Okay, is PRC applicable in stage 4 where there is pancarpal arthritis or a midcarpal arthritis? This is a question from a viewer.
Yeah, we can do that, but for doing this prerequisite is we have to see the cartilage status of the capitate head, and this is better seen by arthroscopically. But since we don't do this and see arthroscopically, I always explain patient preoperatively. And during surgery, we see the status of the cartilage, and if there is less than 50% erosion, we can always do capsular interposition and do PRC. Particularly in young patients, because always we can convert it into wrist fusion later on.
So in short, for stage 4, it is not practical. For stage 3A, 3B, you could still do it, and that would depend on the status of capitate cartilage.
Yeah, yes, sir.
Is that right? Yeah, thanks, Amit. We have had a wonderful session, and it's my pleasant duty to summarize this session before we move on to the next one. We had first talked by the Big W, and he talked to us about role of arthroscopy in scaphoid non-union fixation. I think this is something new that is coming up. Something very important is 100% sensitivity of clinical examination in diagnosis of scaphoid fractures. So we really have no right to miss a scaphoid fracture when we have evidence that there is 100% sensitivity of clinical examination. For percutaneous screw fixation by Amit told us that microplanning is important. Where you are sitting, whether you are sitting in the axilla, whether you are sitting in the shoulder, where the C-arm is, and all precise instrumentation. You must have the correct gauge of the needle, correct gauge of wires, the correct drill. Then only minimally invasive surgeries are possible. When you're doing minimally invasive surgeries, always watch the dose of radiation that you are receiving. Anil spoke to us about carpal instability, and he really simplified the concept of VC and DC for us. At times, we have to realize that many patients are going to present in a dynamic instability stage, and the instability may have to be provoked by provocative maneuvers, and the X-ray have to be taken during those provocative maneuvers. Also, the healing potential of the ligament needs to be assessed. One important factor being the timing of presentation, and that could decide whether you want to do salvage or you want to do repair. Then Amit spoke to us about the Kienbock's disease. Very important factor in treatment of Kienbock's disease that we need to remember is PRC is not a solution for late Kienbock's disease. It is, in fact, it works best when the articular cartilage is in the best condition. So PRC, though it looks like a very mutilating procedure, it is actually reserved for early Kienbock's disease. And the last talk was by Dr. Shailesh for CMC arthritis. One very important factor that he talked about was subluxation of the CMC joint makes it prone to arthritis. So if you see a subluxated CMC joint which is becoming painful, you might want to tackle the subluxation before the joint becomes completely arthritic. So that summarizes the session, and I thank all my speakers in this session. Though we are overshooting time, I just looking at the topics, I just thought we should just allow it. Thank you very much. Over to you, Amit.
Yes, thank you, Pankaj sir. It was a very nice session on wrist. Now we will move to our next session, which is on fractures of the phalanges, metacarpal, and dealing with stiff hand. These are the very common problems in our routine clinical practice. So without wasting time, I will call upon our first speaker, Dr. Rajendra Nehete sir, to talk on mallet finger. Over to you, sir. Please share your screen.
Yep. Yeah, good evening, everybody. And let me thank Amit, Pankaj, and team for organizing this. And I really find it myself very interesting. So if you talk about a mallet finger, so overall, when you talk about extensor tendon injuries, the tendon is flat, it is subcutaneous, and the core suture which we take for flexor tendon is not possible in the at least up to zone 5. So the repairs are weak, and zones 1 to 4 repairs are not usually amenable to early motion protocols, and that makes it really difficult to treat extensor tendon injuries. So when we measure the outcomes of the extensor tendon repair, the loss of digital flexion may be greater than the residual loss of extension. And it's very important because if you mismanage, you will lose a flexion. And normally we should get extension lag, but you get a flexion loss also. So the Millers has classified this into criteria, the excellent and good, The excellent is when there is no extension lag and no flexion loss, whereas good is less than 10% of the extension lag and more than 20% of the flexion loss. So if you see the mechanism of mallet injury, it is the drop finger, what we call. It's basically because of forceful hyperflexion of the distal phalanx. Usually we get because of the cricket injuries, and some of them because of the volleyball and basketball. So as shown in the diagram below, the disruption of the extensor tendon mechanism at the DIP joint, it may be associated with fracture of the articular surface or may not be associated with. But the unopposed pull of the flexor tendon will lead to a drop finger. And if you don't treat the mallet injury, obviously it will, a chronic mallet injury, it will lead to a swan neck deformity. And then it becomes disabling for the patient for use of the hand. The Doyle has classified the mallet finger. All of us know it. Type 1 and type 4 are close injuries, while type 2 and type 3 are the open injuries. I will not talk about it in detail, but what we follow is a meticulous examination and evaluation of the patient, and then follow the appropriate treatment, because unless we don't follow the appropriate treatment, the patient will have a deformity later on. So type 1 is a closed injury with or without small avulsion fracture of the distal phalanx. So I talked about the mechanism of injury. And what treatment protocol we follow is we splint them in 6 weeks in a mallet finger splint. And then after 6 weeks, we ask them to remove off and on while working. It may be allowed, but continuously splint it in the night. And again, after that, night splintage for further 4 weeks. Daytime, they can keep the splint away. So totally 14 weeks supervised treatment is required. And I always find it, patients who meticulously follow the treatment, they get a good result. Whereas those patients who drop out from the supervised treatment, usually they have a poor results. So this was 24-year-old male with cricket ball injury on 19 March 2013, and left finger mallet, no evidence of fracture on X-ray. So this is what we use a splint. Normally the commercially available splints like this, usually they don't fit in very well, and whenever patient comes, if we ask for this splint, they are not available in appropriate size. I find another problem with the frog splint because it leads to maceration of the skin and the skin problems on the dorsum. So we customize the splint like this, and we call them every week and supervise it. And I find it really useful because the appropriate angle can be given, whatever you require for the extension of the DIP joint. And this is this post-op follow-up at 5 years. You can see there is small little bit of flexion loss. And this is his video. So there is no extensor lag, but there is flexion loss, but which is less than 20 degree, in fact 10 degree. And he got an excellent result. So if you follow the treatment meticulously and if patient is really sincere, they get a good result. Type 2 injury is an open injury with laceration of the tendon. And many authors describe this to suture skin and tendon together, but I'm really afraid to put skin and tendon suture together because of the conditions in which our patients are. And I tried to do it in 1 or 2 patients, but both patients I had a problem of infection. So I don't do that. So what I do is open them and repair them. So this was a mixer injury which was already treated by somebody just by dressing, and there was a wound. So we opened it, did the repair. Here sometimes you can take zigzag sutures, but I take the 2 mattress suture in this particular case with 5-0-ethylon and then close the skin. This was March 2012. And in some patients, if I'm operating them, already given local anesthesia, then I prefer to put axial K-wire for 4 weeks. You may find tough in some patients because one patient we had infection because of such K-wire, and this patient led to osteomyelitis of the DIP joint. But overall, we are quite happy with that. And then after removal of K-wire, we ask them to splint for next 6 weeks intermittently, like I told, for the conservative treatment. And this is 6-year post-op photograph. And I asked this patient a video from her house. She sent me. video is not very appropriate, but you can see there is no extensor lag, but there is little bit of flexion loss. Type 3 injuries is open injury with loss of skin and tendon substance. And if there is loss of skin and tendon, then you need to put a tendon graft and a flap cover with DIP joint immobilization. But I have never dared to put a small tendon graft there and cover it with the flap also. So my preferred treatment for such patients is DIP orthodesis. Obviously, there are many devastating injuries like this. 45-year-old lady who had a mixer injury on 2009, and the bone was also damaged, the joint was destroyed. So simply doing orthodesis and covering with transposition flap, I think solves the problem. And this is a 3 years post-op photographs. You can see there is a good flexion and good extension. But the DIP are orthodes, but she is very happy with this result. When we come to type 4 mallet fracture, I have no experience in treating trans-epiphyseal fractures in children because I didn't get any. But the type B is hyperflexion injury with intra-articular fracture 20 to 50%, and more than 50% of the articular surface is a type C injury. So type 4, it requires open treatment. And my method of fixation is either a screw fixation, K-wire, or extension block pinning. If it is a small fragment, I have managed to do it conservatively also. So hyperflexion injury with intra-articular fracture, you can see a small fracture fragment after cricket ball injury. That was in September 12. And this, I just repaired the extensor tendon because it was completely disinserted with a small fragment of bone. We just repaired the extensor tendon with soft tissues and immobilized with K-wire. And this is a 6-year post-op result. You can see scar on the DIP joint. He has good flexion also and good extension also. You can see this post-operative video after 6 years. And type C injuries, where hyperflexion injury with more than 50% of the articular surface. This was a ring finger mallet. Usually these patients don't present to me immediately on day one. Hardly they come on day one. Usually they come around 2 weeks to 3 weeks, when actually the mallet finger becomes more apparent because of the drop finger. This was an injury in May 2015, and the date of surgery was 16th May. And you can find a small screw as well. I have immobilized it with the K-wire. And this is a 3 years post-op. You can see little bit of extensor lag in this patient. So recurrence of a surgery, many times if you fail in the surgery after extensor tendon repair or even after the fracture fragment, but we had no complications related to splint because we use a customized splint. This was a patient with cricket ball injury, and he had this small fragment. So I thought it will, because it was fragmented, I thought it will not be better to put a screw into this because it may just fragment further. So I did intraosseous wire. I'll show the X-ray, and immobilized it with K-wire. But then when we removed the K-wire, it dropped again. So obviously the intra-articular intraosseous wire didn't remain. But after looking at the X-ray, what I did was just immobilize it. This was the initial X-ray. And then again immobilized it in a splint. And this patient was really very sincere and he followed up very well. And we had a good result. This was June 13. And you can see this X-ray, the bone is united, the space in the joint is also good. You can see a distally migrated intraosseous wire. But this is a post-op, 5 years post-op view. You can see there is small little bit of deformity in the nail. And this is one of the complications of the mallet finger surgery. And you can see 5 years post-op video. There is no extensor lag or there is no flexion loss. So, but our preferred method today is external block pinning because I find it less invasive. And this was a patient with cricket ball injury. And you can see a small fragment out there on the dorsum. So this is the type of external block pinning what we use. You have to take care that your pin should not go into the substance of the flexor tendon. Otherwise you get adhesion there and then there will be significant flexion loss. So this was 8 months post-op photograph. You can see little bit of flexion loss, but he has a good flexion, good fist, and good extension, no extensor lag. So we have good to excellent results in almost all the patients except the complications, but they were also treated well. The extensor lag is less than 10 degrees and the loss of flexion is less than 10 degrees in almost all the patients. So if you meticulously choose patients and clinically evaluate them and treat with the proper protocol, I think all of them, they should get a good result. Thank you very much.
Okay. Thank you, sir. That was
you require a good cooperation from the patient. Thank you, Amit.
Yeah, thank you, sir. That was a very nice presentation. You can please stop screen sharing. Yeah. So there are a few questions from the viewers. Is there any role of fusion in case of chronic mallet finger? So can you hear me?
Yes, now I can hear you.
Yeah, there are some questions from the viewers.
Yeah.
Is there any role of fusion for chronic mallet finger?
Chronic mallet finger, yes, yes, if it is involving a bony fracture, and if you are afraid that it may lead to osteoarthritis and a painful finger, then it may be better to do orthodesis. Especially in some of the manual laborers, you may prefer to do it. But I want to do it primarily for any of the patient who requires a good hand function. I will always try to treat them surgically and try to give a better result.
Okay. So one more question, sir.
Yes.
What will be your line of treatment when there is a mallet and beak on the dorsum of the distal phalanx?
Beak.
Beak.
Okay. Even if there is a beak, I don't find any problem. I always try to treat them with the open method. And sometimes we have to do a refracture of the fragment which is malunited, which leads to a beaking. And you can treat them well in spite of the beaking in a chronic mallet also. But then already that time, sometimes there is an established one neck deformity, and you may have to release the PIP joint and release the lateral ligaments so that you achieve a good flexion at the PIP joint.
Okay. Okay. Thank you very much, sir. Now I will invite Dr. Parag Lad to talk on metacarpal fractures, techniques and management. Parag, please share your screen. Okay. We can see your screen. Yeah, please go ahead.
Parag, unmute karo.
Yeah, we are not hearing you, Parag. Please unmute yourself.
Yeah, can you hear me now?
Yeah, now we can hear you.
Okay.
Before
we discuss the metacarpal shaft fracture, I would like to discuss some relevant anatomy about the metacarpal in the hand. As we all know, second and third metacarpal, it angulates, and the second and third metacarpal base, so second and third metacarpal behave as a fixed unit with the carpometacarpal joint, and they do not have any mobility there. And in fourth and fifth metacarpal, they have 20-degree or 15 to 20-degree movement at the carpometacarpal joint. In the metacarpal, on the head part of the metacarpal, there are recesses on either side. They give attachment to the collateral ligaments. Because of this pertinent anatomy, second and third metacarpal accepts 5-degree angulation and no shortening, and fourth and fifth metacarpal shaft fracture, they accept 15 degree of angulation and 2 millimeters of shortening. If the shortening and angulation is more, the grip strength of the hand is certainly weakened. Another important anatomical aspect is second and third metacarpal base, they receive important big tendon insertions like wrist extensor ECRL inserts at the base of second metacarpal, and ECRB is inserted at the base of third metacarpal, and ECU is inserted at the fifth metacarpal base. Here important point is fourth metacarpal does not receive any attachment.
And these tendons, when they act, they have default, I mean, they contribute to the fracture displacement. Now, otherwise, metacarpal fractures are same classified as per the any long bone fractures in the human body. There could be a short oblique fractures, there could be a transverse fracture, there could be a oblique fracture or fractures around the joint. But the main concern here is there could be a shortening, there could be a angulation and rotation. These are the main concern. When we consider a rotational malalignment, which is shown in this picture, the little finger is turned on the outer aspect or the ulnar side, and the right hand of the ring finger is little finger is shortened as compared to the left hand. Now, if you see, the indications for fixation are irreducible fractures, unstable fractures, intra-articular fractures, multiple fractures, and fractures with the bone loss. These are the indications for fixation. Metacarpal head fractures. The mechanism of, now we will see each and every anatomical part with one simple example. Usually head of the metacarpal gets fractured in case of axial loading and direct trauma to the hand, or sometime in a in the revenge of anger, if somebody bangs his hand on the wall, then they get a injury to the head of the metacarpal. As discussed, we usually should get a Brewerton view as shown in the X-ray picture. Let us take a treatment option if the articular fragments are not completely involved or less than 25% involved, and the 1 millimeter only, I mean the step less than a millimeter or 2 millimeter step, then we can consider a conservative treatment. Otherwise, the option of open reduction and interfixation is there, but sometimes the head is so comminuted that salvage option of a arthroplasty may have to consider. Let us take one example. If you see this X-ray, 30-year-old female, and if you see this X-ray on a AP view, the metacarpal head is flattened, and on an oblique view, the head seems to be fractured, which was treated by open reduction and internal fixation with the screw. I have used a simple screw, but the best choice of implant here would be headless compression screw, so that it does not, the screw head gets sunk into the bone and it does not interfere with the movement. Now, if you discuss about metacarpal neck fractures, it is most commonly seen in ring and small finger. Though we label them as a boxer's fracture, it is rarely seen in boxers and commonly seen in street fighters, or somebody hits on a solid or a hard object, then such fractures can happen. When the angulation is accepted and if there is no rotational malalignment, we can treat these fractures by conservative treatment as mentioned in the picture. The maneuver is called Jazz maneuver, where we flex the PIP joint and we flex the MCP joint, and we try to push or reduce the metacarpal head fracture by pushing the proximal phalanx onto the head. But now let us take an example of a short oblique fifth metacarpal distal fractures, where these types of fractures are reasonably rotationally unstable. And the best way to fix this fracture is by close reduction and a bouquet technique. In this technique, as discussed, the 2 millimeter hole is created on the proximal part of the shaft, and 1 millimeter wire, by cutting their distal tip, we insert and we maintain the proper alignment and angulation is corrected. So that was a distal shaft fracture. Here the X-ray shown, here we see a sometime a significantly angulated fracture at the neck level, 60-degree angulation. This is not accepted because sometimes this fracture can cause, the displaced fracture can cause palpable bone in the palmar aspect of the hand, and they can be treated by a bouquet technique. So another example here, the bone contact of a metacarpal head with the neck or with the shaft of the metacarpal is not there. Such fractures are completely unstable. I have found difficulty in reducing and fixing them with the bouquet technique. So another way of fixing them is after reduction, you pass a wire distal to proximal. But here, sometime your wire may go from a sagittal band or a lateral recess, which can cause MCP joint stiffness during mobilization. That was about the metacarpal neck fractures. In metacarpal shaft fracture, we have to have these four parameters, if the fractures are completely displaced, or if they show rotational malalignment, and if the angulation is more than 15 degrees, and if the fracture configuration is comminuted and displacement, we need to fix them by surgical intervention. In multiple fractures, it is necessary to fix these fractures, otherwise the stiffness is unavoidable, and sometimes we have to fix this fracture by interfragmentary compression screws. And remember, when we have multiple fragments, I mean the multiple fractures of the metacarpal, the approach is, when you want to fix the second and third metacarpal, then you have to use second intermetacarpal space as a incision and approach to these two fractures. And when you want to fix fourth and fifth metacarpal, you have to take incision on the fourth intermetacarpal space. So let us take another example. These are the patient is having in this X-ray as shown third and fourth metacarpal long spiral oblique fracture. But when we see these X-ray, do not miss the fifth metacarpal base fracture also while fixing this. So otherwise, as we have discussed, why they are important, I will tell you again. So this is one way of fixing the spiral oblique fracture by cerclage wiring. Very thin gauge wires we can use on circumferentially to fix this fracture. And fifth metacarpal fracture has to be fixed, the base fracture has to be fixed. Sometime you get such spiral oblique fractures. These are reasonably unstable fracture. Sometimes the general attitude is, if the central bone of the hand, that is third metacarpal, is fractured, then usually we can have a reasonably good function. But it does not, that is not true. In this as shown, this is the absolutely wrong way to do a strapping of any metacarpal fractures. Reduction cannot be maintained in a spiral oblique fracture, and rotational malalignment is always the rule. So this was the X-ray after removal the strapping. Just see the skin maceration at the MCP joint crease, and this has happened within 8 days of strapping, and patient was advised strapping for 3 weeks to continue. But then such fractures being spiral oblique, I had fixed with the rotational malalignment, and immediately on day 1 with the dorsal slab we start the movement. And usually these fractures heal in 1.5 to 2 months, but our functional recovery is achieved very soon, and usually they do not land up in any deformity. Look at the knuckle prominence of third metacarpal after the plating. So they usually have near normal function of the hand. Let us take now, sometimes the transverse fractures of the metacarpal shaft, if they are angulated and they are moderately displaced, they can be accepted by conservative treatment method of treatment. But here the problem is, these two bones have significant shortening, more than 5 millimeter shortening. Now we have to always remember, whenever somebody makes a grip of the hand, the ulnar aspect of the hand has to be stronger. Here, as shown in the X-ray, fourth and fifth metacarpal are fractured, so the grip of the hand will be significantly reduced. And as there is a shortening and angulation, the prominence of fourth and fifth metacarpophalangeal joint knuckles will be always lost. So such fractures are being unstable. We would prefer to treat them by plating. That is the reason for doing plating is we can start mobilization early. And now if you see, the height of the metacarpals have reasonably regained well after the fixation. Now, so we see this X-ray. It's a long oblique third metacarpal shaft fracture. Don't miss first now here, if we concentrate only on the metacarpal shaft, always look for associated injuries. This patient had a first metacarpal base fracture also. Usually we get the opinion on WhatsApp, what is the treatment, and then we suggest the treatment to the concerned orthopedic surgeon. But always ask them to show the photograph of the hand as well. The same patient with these two fractures had a full blown compartment syndrome, and I had to do the first compartment release. And after the compartment release, the swelling became significantly less, and in the same sitting I had done a fixation of third metacarpal shaft with interfrac screws, and first metacarpal base I had to put a wire. Now after the shaft fractures, the last method is the last way part of the metacarpal fracture is base fracture. Fourth and fifth metacarpal base fractures, they are called reverse Bennett fracture, And usually this one bone, fifth metacarpal base and fourth metacarpal base, they articulate with one bone, that is hamate. These fractures are reasonably unstable because of three reasons. The acting forces on these metacarpal base is very strong by the extensor and flexor tendons as well as adductor digiti minimi tendon, I mean the muscle, and the surface of the hamate is oblique. So whenever they have a fracture, there is significant amount of displacement. And these fractures, if they malunite, they have significant pain and reasonably early setting up of arthritis in the carpometacarpal joint. So such fractures have to be treated by, I mean, I have chosen to treat this fracture by K-wiring and uniplanar Jess fixator. So you get a reasonably good alignment of the fifth metacarpal, and the entire fourth and fifth metacarpal unit and the articular surface has been congruent well, and the reduction has been achieved in a well manner. So this is 10 days post-op. You can start movement immediately after the surgery, and this is the movement, I mean the function at 2.5 months. So sometime you get a rare entity that is called Lisfrank's fracture dislocation in the hand. You see, because second metacarpal base has a fixed unit with the carpometacarpal joint, it has not displaced. But otherwise, third, fourth, and fifth metacarpal base have completely displaced from the carpometacarpal joint. Usually, they need a CT scan for understanding the fracture anatomy and the displacement and articular fragments, and they usually need a fixation from metacarpal to carpus, and they usually have good function if you stabilize them. Message here is there are three problems in the metacarpal fractures, and they are real indication for surgery. One is rotational malalignment, second is deformity, and third is shortening. And conservative treatment is the way to treat these fractures, but then that needs very regular follow. Always look for associated injuries, like if you are treating a third and fourth metacarpal base, always look for thumb metacarpal as well. Always look for a soft tissue injuries and compartment syndrome. And complete function should be the goal, whether you treat or choose to treat them conservatively or surgically. Thank you so much. I thank Dr. Amit and team for giving me an opportunity.
Thank you, Parag. That was a very nice presentation. There are some questions from the viewer. In case of metacarpal neck fracture, while doing bouquet technique, does thin wires bend?
So there are two things. If you use, I mean, if you hold the wire too long from the hand, then they will bend. Second is, if you don't pre-bend the wire before, and if you don't bend the angle in an acute fashion at the tip, then they will bend. So the trick or tip here to give is you should make a big hole. I mean 2 millimeter K wire or 2.7 drill bit that can be used to pass the wire, and 1 millimeter or 0.8 millimeter wire should be used, and that has to be hold at the tip very nearer to the hand, not away from the hand. Then it will not cause any bending.
Okay. So there is one more question. In case of metacarpal plating, have you encountered problem of extensor lag of finger?
So it depends on, it depends on three things. Extensor lag will happen if you are if you are exposing the extensor tendon near the capsule or very distal or around the MCP joint, then you will have extensor lag. Otherwise, in metacarpal plating, we don't split the tendon, we just retract the tendon. And I try to preserve juncture tendoni, or if there are multiple metacarpal fixations, if you preserve juncture tendoni, and if you put the plate by retracting the tendon and not by splitting the tendon, then definitely you will not face this problem of extension lag.
Okay. And one last question. Just share some tips for putting K-wire into the metacarpal. Which structures can be injured and how to avoid that?
Okay, so you are, I mean, the K wires for, suppose say fifth metacarpal neck fracture, if you want to put a K wire, always look when you are seeing the K wire insertion in the X-ray, always put the wire on the sides of the finger. Do not put from the dorsal central aspect of the finger. Otherwise, you are going through the extensor tendon, then your mobilization will be definitely difficult and it will have a stiffness in the MCP joint. So always look for metacarpal recess or the collateral ligament attachment and put the wire from the sideways. Second thing is, when you are passing a wire from the dorsal part of the proximal aspect of metacarpal, take a proper 0.51 centimeter incision, dissect the skin and soft tissue so that you are eventually dissecting the dorsal cutaneous branch of the ulnar nerve and you don't injure it invariably. So these are the two things that we should take care.
Okay, okay, thank you, Parag. Now I will invite Dr. Pankaj Ahire to talk on acute PIP joint fracture dislocations. Over to you, sir.
Thank you, Amit. It's my now pleasant duty to talk about PIP joint fracture dislocations. Thank you very much. So this was a 52-year lady. Amit, this lady is from Nashik. I think you saw her.
Yes.
You remember this, yeah. So ambidextrous, very high office in government, had a trivial trauma, got this fracture reduced, dislocation reduced. Apparently it reduced very easily. And this is how she presented to me. There's a temptation not to do anything for this or just leave them alone and allow them to mobilize. But remember, this dislocation happened because there was some soft tissue disruption. If not treated well, this joint will become unstable. So the thing to watch for is a hyperextension attitude at the PIP joint. This indicates that the volar restraints have been disrupted, and therefore we need to protect this joint in flexion. At the same time, we want this joint to move. So attitude of flexion is important, movement is important, otherwise it's going to be stiff. So the solution for such issues is what is called as the extension block sprinting. There are various ways of doing an extension block. This way, this method allows the finger to move. At the same time, it offers the extension block. So, and she eventually did very well in this. Now, this is another young boy. Obviously, here the soft tissue disruption has happened with a bone avulsion. You can see there's an avulsion of an extensor tendon on the dorsum and the volar plate. This patient again had a very stable joint and a good range of motion when you present it. So when a person presents with a reduced joint, no hyperextension, and has more than 50% range of movement of the PIP joint, and the joint remains stable through that motion, these are the patients who can be treated conservatively and non-operatively. This patient was simply treated with splinting and was allowed to mobilize. Now, it's very important that you decide who are the right patients for non-operative treatment, because patient must understand your instructions. Patient must understand that they are not supposed to hyperextend passively. They are allowed to move their hands, but not use their hand for all the day-to-day activities. So patients who are reliable, who are likely to follow your instructions well, are very good candidates for non-operative treatment in such conditions. And this child also went on to do very well. Then why do we ever need to fix these fractures? So just look at this. So we have, just ignore the labeling here. This is the proximal phalanx. This is the middle phalanx, and these are the red one is the collateral ligament proper, and the yellow one is the accessory collateral ligament. Now, this is the same layout. This is the proximal phalanx, middle phalanx, and this is a common presentation of a fracture. Now, this type of fracture presently will present only as a sprained finger and gets maltreated. So just look at how do we decide whether to fix or not. Now, you just take out the uninvolved proximal phalanx. Just look at the base of the middle phalanx now. And this is where the fracture has happened. That's your base of the middle phalanx. As you can see, there is about 30 to less than 50% for sure involvement of the articular fragment, and the articular fragments are here. Now, these are the fractures which, when with dislocation, which when reduced, generally remain stable. And why do they remain stable? Because the collateral ligament is attached to the larger fragment here. So the joint is stable. Now, if we simply reduce it and leave it alone, then this volar fragment will still not unite with the middle phalanx, and this creates a potential situation for instability. So how do we make this fragment unite with this? Simply by putting the finger in flexion. So this is the principle of flexion block, or treating this patient in an attitude of flexion. Remember, this fragment is not a flexor tendon avulsion. This is not a FDS avulsion. FDS is attached somewhere here in this area. So these patients are allowed to flex, but not allowed to extend. How will we not allowed to extend them? Either by putting an extension block K-wire, and then they are allowed to flex, or we can simply put a dorsal splint and allow them to flex. In the end, what you get is a finger, which is the joint is is congruous, and the joint may be in the in an attitude of flexion deformity. Flexion deformity is very favorable as far as joint reduction is concerned. Now look at another situation. Same thing, just remove the proximal phalanx out of equation, just focus on the base of the middle phalanx, and now you can see that this is definitely more than 50%. Now these are the joints which are, even if you reduce them, they will remain extremely unstable. These are the joints who require more than, they might require more than 60 degrees of flexion to reduce, to keep them reduced. Now that is not acceptable. You cannot keep a joint, PIP joint, flex more than 60 degrees for until this heals. So these are, and why do these require so much of flexion? Because here the ligament is attached to the volar fragment and not to the shaft. So they are potentially unstable, and even if they reduce, they require extreme flexion. These are the fractures which require some amount of fixation between the middle phalanx and the dorsal lip. The fixation can be anything. It can be screw, it can be a pull-out suture, it can be an anchor, and
Yeah, we cannot hear you. Are you there, sir?
I think his connection broke.
Okay.
He will get disconnected. So you want to continue? See, he's got disconnected now. So yeah, he's back.
Yeah, yeah.
So, sorry?
Yeah, okay, no problem. You can share your screen again.
Why? What happened?
You got disconnected.
Oh, I was not aware at all.
Yeah.
Okay.
Just for 2 slides. No problem.
Okay.
Just get that fixator X-ray of lateral view.
Oh, I'm sorry. I just did not realize it. Okay. This is where we were, right?
Yeah. Right.
So these are the cases in which we need some sort of fixation between the proximal and the distal middle phalanx and the volar fragment, and the external fixator is used here only as a neutralization device. And I'm not otherwise a very big fan of external fixators for treatment of fracture dislocations of PIP joint. This will give you a joint which is reduced well, and there is a flexion deformity. Flexion deformity is good for PIP joint fracture dislocation because it can be very easily be stretched out, and it's the flexion attitude which maintains good reduction of the fracture. Take this example: 2 weeks post-trauma, intra-articular fracture, severe comminution, and these fractures are perfectly amenable to a proper open reduction, just like we would do for any other intra-articular fracture dislocation. Trying to treat this by external fixators may not be a great idea, and you can get a very good range of motion when these fractures heal. And we really do not have to make them suffer by stiff PIP joints. This is another example where there is an articular depression. Now, if you have an articular depression in any other joint in the body, what would you do? You would do open reduction. You will reduce the articular depression, and you would fill that area with bone graft. That is exactly what was done here. You have an anatomical alignment of the joint and a good reduction of the joint surface, and this is what you get as early as 2 weeks. Occasionally you may have severe comminution in this area, and then this may look like irreducible. But even in these cases, remember, if you have a good articular cartilage which can take part in the joint movement, we can still put the pieces together. It may not be amenable to fixation by screw. I have simply put a pull-out suture here and allow it to move. And as I said, I'm very happy if I see a 30-40 degree flexion deformity and a well-healed joint. I know I will be able to stretch out this flexion deformity using a Kapner's splint. Occasionally, you will have a situation where there is a large part of the volar part is missed. And even in an acute setting like this, you may have one of the two options to be used, what is called as a volar plate arthroplasty, something like this. This was a neglected joint, and this fragment would not have been possible to fix. So this is what was done for this patient. So this gap here is filled with volar plate. That is what is called as the volar plate arthroplasty. Volar plate arthroplasty and hemi-hamate osteochondral grafts are options which are available to us for treatment of non-reconstructible acute dislocations as well as for chronic dislocations. So I will just outline the principle of the volar plate, because in a subsequent talk, Dr. Binu Thomas is going to talk to us in detail about the chronic ones. So this is the principle of volar plate arthroplasty. If you see, this is the dorsal dislocation, that is the volar plate, and that's the attached bone fragment. When these bone fragments are not fixable, we simply remove them and advance the volar plate inside the joint, and it is pulled. It takes replaces the articular cartilage in that area, and this is how it works. And this also gives excellent range of movement. This is the example of volar plate arthroplasty.
Sir, may I interrupt you?
Yeah, tell me.
Yeah, this will be covered by Binu, sir.
Yes, I'm 100%. So I'm just outlining the principle. Again, a similar case where if there is a more than 50% loss, this cannot be treated by volar plate arthroplasty, and this requires a procedure called hemi-hamate arthroplasty, which will be covered by Dr. Binu Thomas in detail. This is a hamate graft which replaces this. So in short, the principle is, if there is a pure dislocation, please understand there has to be a volar plate injury. If there is a stable fracture pattern, it can be effectively treated with a close reduction. However, the patient has to be very, very reliable in terms of following instructions. If there's an unstable fracture pattern, it needs fixation. If there is a neglected fracture dislocations, you may have to do a volar plate arthroplasty or a hemi-hamate arthroplasty, which Binu will take us through. Thank you very much.
Thank you, sir. That was very nice talk. So some questions are there.
Sure.
Yeah, in case of central pylon defect of a 1-month-old PIP joint fracture without dislocation, how will you manage that?
So if there is no dislocation, there is only a articular depression.
Yeah.
So this introduces us to two terms, what is called as the articular congruity and what is called as the articular cartilage congruity. So this is a joint which is reduced. So there is an articular congruity. The joint is congruous. However, there is an articular cartilage which is disrupted. I would leave it alone. If the joint is reduced with an articular depression, I would just leave it alone, because what you require is a congruous joint. An articular cartilage defect is acceptable.
Okay, thank you. Just quickly, one more question as we are lagging behind time. So just share a small tip about how to fix volar fragment as it is hidden by the volar plate, and which size screw you use.
Okay, for volar fixation, you use an extensile approach like similar to what we do for shotgun approach. Flexor tendon, the FDS can be retracted. It does not have to be divided. Underneath, you will find a volar plate. If you are planning to fix the fractures, if there is only an articular depression that you want to correct, you can simply lift the fracture fragment with the volar plate and reach the articular fragments. However, if there's an entire the lift fragment is completely displaced, then you may have to detach the volar plate, do what is called as a shotgun approach, which Binu will show us in next talk, fix the fragments under full vision by dislocating the base of the middle phalanx, and then reduce. The screws that I use is 1 millimeter screws. At the most, I would use a 1.3 millimeter screws. Anything larger than 1.3 millimeter screws is not advisable. I would use 1 mm screws in as many numbers as required, sometimes 3, minimum 3. sometimes 4, sometimes even 5 screws.
Yeah. Okay. Thank you. Thank you for the talk. Now I will invite Professor Binu Thomas to give a talk on chronic PIP joint fracture dislocations. Sir, over to you. Please share your screen.
Thank you very much, Amit. Let me just, yeah. So I'm talking about the management of chronic PIP joint injuries, and you have to understand that it's a spectrum of injuries, not just one thing. As Pankaj has already done most of the talking, I will just show you a few things where you can have an open injury, you can have injuries that are late, malunited, or most of them actually come with a very stiff and painful finger. That is, it doesn't move. The PIP joints are very, injuries are very common injuries, and usually can be improperly diagnosed or treated by the physicians, and many injuries are usually also considered trivial by patients. It will be interesting to note whether these injuries are now less because of our, the corona situation, because we are not playing cricket. That is where we see most of these injuries. And we had a mention about these things, how the collateral ligaments and the volar plate are the soft tissue stabilizers of the joint. And this together with the volar plate in the volar aspect and the collateral ligaments on the sides form what is called the ligament box complex. So this is very important for the stability of the PIP joint. And that's a soft tissue stabilizer. The bony stabilizer is the congruent articular surfaces, as you can see here, and the structure what is called the volar buttress. This is the volar buttress. It is the volar, about 50% of the volar bony area, which provides the stability. This is the most important structure. And here in these fracture, you can see that the volar buttress is gone and the joint has dislocated or subluxated. So this is very important to reconstruct this structure in a chronic injury. And the spectrum of chronic injuries, as Pankaj had mentioned, there is a volar plate injury, which can become chronic. Collateral ligament injuries where the joint opens up. The central slip on the dorsal aspect can be injured. These are all the soft tissue injuries. And the bony injuries are the fracture dislocations. And the other ones are the pylon fractures. So all these can produce chronic injuries especially when these are more than 6 weeks old. I'm not going into the clinical evaluation much, but painful swollen joints, always be careful. You must get, as Vipin was telling us, a true PA and lateral of the injured finger. That is very important. Other investigative modalities are the ultrasound and CT scans and occasionally MRI. So do not accept an X-ray of the hand in these injuries. Always look for the finger injury X-ray. For this is an example. Here you have a hand AP and oblique views, which are commonly what you get. But see what happens when you see a lateral view. So there you can see. So this is the most important thing about radiological investigation. In a chronic injury, you look for this V sign. It suggests a persistent subluxation. So look for the V, and if it is there, you know it's a persistently subluxed joint, and it needs treatment. Late presenting volar plate injuries, even though it's a hyperextension injury, presents usually as a flexion deformity. There are various investigative modalities you can use if you're in doubt, and you can give a trial of physiotherapy and splinting, but most of the times they may need a surgical volar plate release like this. This is the zigzag incision to expose the joint of the PIP or the volar approach.
Sir, you are not audible.
You're not audible?
Yeah, now it is okay. Please go ahead.
Okay. If I'm not too audible, you can shut off my video of my face. Then I think the bandwidth improves.
Yeah.
The other one is collateral ligament injury, which are very difficult when you have a radial collateral ligament injury because the thumb keeps pressing the finger digits. So if you have a radial collateral ligament injury of the digits, it opens up and it becomes very painful. This may need, again, investigations help like ultrasound, and may need ligament reconstruction. Either direct repair is very unusual at 6 weeks or more, and we may need a reconstruction with the graft like a palmaris longus graft. The other thing you have is these chronic PIP injuries presenting as a buttonite deformity. You can get a hyperextension of hyperflexion injury, presents as flexion deformity at the PIP and hyperextension at the DIP joint. This is the buttonite deformity where characteristically the lateral bands sublux volarwards and produces the PIP joint flexion. And early enough, if you want to get the management, you do this Elson test where you keep the finger on the side of a table and then try to extend against resistance. So if the DIP joint is taut, it means the central slip is ruptured. So remember the Elson test when you assess a patient. Chronic injuries, you can reconstruct the central slip by multiple techniques are available in the literature. I usually prefer a palmaris longus graft, or sometimes I use a split lateral band and approximate it into the center. Very rarely, you may have to do a PIP fusion. Dislocations, of course, you've never generally see an acute chronic dislocation unless it is irreducible because the lateral bands or a flexor tendon interposes. And so in those situations, you may have to do an open reduction and remove these interposed lateral bands or the flexor tendon. Also, look after these volar dislocations. They are very rare, but here you can see the dorsal lip fracture. That is, the central slip is attached to that. It needs reconstruction. We've already, Dr. Pankaj has taken us through this, the injuries, the hyperextension, dorsal dislocation, and the fracture dislocations. So when more than 30% of the volar buttress is fractured, the joint becomes tenuous. It has got this tendency to subluxate dorsally. And definitely more than 50%, it is unstable. So these treatment is different, as we have already seen. And when they are chronic, it becomes more difficult to treat and will need some of these procedures which have already been mentioned. And we have to reconstruct the volar buttress. So the management options are limited in these. You can do a distractor application, volar plate arthroplasty, but the preferred technique on this is the hemihamate replacement arthroplasty. Also, sometimes if it is very chronic, you may have to do a PIP joint fusion. So what is this hemihamate replacement arthroplasty? Let's a sentence about volar plate arthroplasty. Dr. Pankaj has already shown it. It is just putting the volar plate where the volar buttress was. I like to do it only when it is less than 40% of the fractured surface. So the hemihamate, it's an osteochondral graft which we replace the dorsal surface. And it was originally described by Hastings. It's very useful in neglected cases. This is what you do. The hamate articular surface is very similar to the base of the middle phalanx. So you can actually replace the volar buttress with a hamate articular surface, this area. So this is what we do. That's a hamate, you can see. We have done some modifications and we have reattached the volar plate for the hamate graft. So this is what you do after opening the joint. That is called the shotgunning. We release the collateral ligaments on either side and we open out the joint, take the hamate osteochondral graft and attach it with screws. So that's the replacing the thing. This is the part of the modifications where we put the intraosseous sutures to reconstruct reattach the volar plate. That's a volar plate being reattached after the osteochondral graft is kept. So here's an example, 17-year-old boy, 10-month-old injury. So that is a post-op and 5-year follow-up. That's the range of movement he has. So it's a very, very good operation for a chronic injury which came very stiff. Distractors can be used. I don't use it. This is a case from my friend Dr. Sudhir. 1-year-old injury, he had a distractor applied, and that is the post-op range of motion. So that is done well. Pylon fractures, again, once neglected, very difficult to do an open reduction internal fixation. They may end up with a PIP joint fusion. We have tried in one of these distractors modification of the Suzuki, and it did reasonably well. What happens when there is osteoarthritis? You may end up with a PIP joint fusion, or I do what is called a volar plate interposition arthroplasty. It is different from the Eaton's procedure. These are the preferred PIP joint arthrodesis angles from 40, 45, 50 from index to little finger. And we don't have this available in India yet, but when it comes, we can use that. So this is the interposition, volar plate interposition arthroplasty, where you put the volar plate as an interposition. Just a couple of cases. 9-month-old injury, patient received no treatment but came just to see me. So this was his range of motion. Question was, he had full movement, I just left it alone. And second case, index finger, 8-week-old injury, he had the classic PIP dorsal fracture dislocation. It was chronic, unstable, and I opted to treat him with a hemihamate replacement. So that was done. That is the open joint, shotgun joint, and that's the end result at 3 months. 5-year-old injury with osteoarthritis. So look at the joint, you can see there's no cartilage. Very painful. He is a professional cricketer. So this is where I did the option was a PIP fusion, but he refused. So I thought I'll try this volar plate interposition arthroplasty. The joint was again opened. That's a shotgunning of the joint. And you see the cartilage is badly damaged. So we mobilized the volar plate and attached it to the dorsal lip of the proximal phalanx. And after this, the follow-up X-ray, you can see that the joint.
Sir, you got disconnected?
There is no extension.
Yeah.
Joint is infected and ended up with a, oops. Can you hear me?
Yeah.
Okay, we debrided the joint and mobilized some rotation, transposition flaps from the dorsum, dual transposition flaps, fused the PIP joint and covered the joint and put skin graft where the original, the donor area. And that was the follow-up. So it's healed well, that's fine. So to conclude, those injuries are not uncommon. You must insist on a lateral view and recognize the specific injury to tailor the treatment. Thank you very much.
Yeah. Thank you, sir. That was very nice talk. I still remember the first hemihamate case when I assisted you, and I was very surprised to see that miraculous joint reconstruction. Yeah.
Thank you.
So only one question, sir, because time is we are lagging behind.
Yes.
So how late you can do hemihamate reconstruction?
That's a very good question, and that is very critical, because what I think is when I open and I don't see.
Sir, you can stop your sharing screen so that
okay.
speaker can upload. Yeah, thank you.
So if I plan for a hemihamate replacement and when I open the joint, I don't see good cartilage on the proximal phalanx, I no longer do it, because putting a time on this is very difficult, because I have done it even at 14 months and has got good results. But at the same time, I had a patient who's actually a dentist who I did at around 9 months, and he went, the range of movement was good initially, but then after about a year or so, it fused. So most important thing is the cartilage on the proximal phalanx head. If that seems to be good, you can go ahead and do
Okay, okay. Thank you, sir.
Thank you.
Now I will invite Dr. Amit Vyas to give his talk on how to deal stiffness of the hand.
I'm audible and my screen is visible.
Yeah. You can start, sir.
Okay. Good evening to all. Thanks for opportunity. There is a variety of presentation of stiff hand which needs individual evaluation and treatment. Hand has a tendency to stiff, and if it is not attended, it will stiff into a position of non-function. Like this, in this example, wrist is stiffened into the flexion. So this is most of the time this stiffness can be reduced. Like this patient was fixed with K wires, and basic principle of fixation was not followed, and principles of immobilization was not followed, and leads to stiff hand into extension at the MP joint, and it is very disastrous condition to deal. So just to summarize this case, this Ganna machine injury, he landed at 10th day and initially debrided, and now we are predicting a lot of stiffness in this condition. So after debridement, we try to heal the wounds with the hand frame, which keeps wrist into dorsiflexion and MP joint at flexion and IP joint at extended. And after 10th day, started mobilizing the MP joints and IP joints with the rubber traction off. So you can see a reasonable range of movement at the of the hand, and he is able to perform all the function. Only the principle of keeping the immobilization were kept in mind. And but in the lateral view, you can see there is a lot of movement at the MP joint only, and IP joints are stiff. So we are able to achieve good results. So evolution of stiffness is most important while treating these type of hands. The stiffness in the hand can be direct or indirect. Like in this example, patient had difficulty in moving the PIP joint, and on X-ray he is having PIP joint fracture dislocation. So this is a direct cause of stiffness in the hand. This lady had this malunited lower end radius. So inside the injury is at the lower end radius, but patient presented with the stiff fingers. So this is the indirect cause of stiffness. So what is the pathophysiology behind the stiffness is the edema. As told by our teacher, that edema acts as a tissue glue. Once the edema occurs in the hand, it floods all around the normal and abnormal structures, and especially in the MP joint. MP joint have a lot of space while extension. So MP joint becomes extended and the flexor tone increases and PIP joints get into flexion. So when these conditions are left untreated or adequate measurements were not taken, it leads to fixed stiff joint contracture. So we have to do measurement to prevent the edema. So etiology for the flexion restriction and extensile restriction can vary from skin to bone block, and I will not going to enumerate the exact cause. So we have to think of these causes to get the exact etiology. For the clinical examination part, first of all, we have to assess the range of movement at the joint. So there may be three types of conditions. Once the passive range movement is more than active range movement, and passive range is equal to range of active range movement, and there is no range of movement. So whenever first condition is there where the passive range is more than active range movement, our suspicion is the musculotendinous structure is the cause, and it may be adhere or it may be incompetent. So and associated contracture may be present. In the second condition, where the passive range and active range are equal. We are suspecting any bony block or capsular injury. So first we will go for the X-ray, and you can see any articular incongruency or heterotopic calcification around the capsule or collateral ligaments. If X-ray is normal, then we will go for the 3 Tesla MRI, and we can find any problem in cartilage or ligament. And this third condition, when there is no range of movement, the evaluation for the cause is very difficult. So in this type of situation, we will try to get some range of movement. So we'll understand with this example. This is a patient having multiple metacarpal fracture, and patient was told by the surgeon that he had some vascular problem, and he fixed with the straight K wires, and he presented with this condition with all fingers straight. We started some movements and able to get some range of movement at the IP and some range at the MP joint. Now we are trying to assess what is the level of affection. It may be adherent extensor tendon or other the flexor tendons. Then second thing, we have to assess the relative joint movement. This bundle test, we all know when MP joint is extended, there is less PIP joint movement. And when MP joint is flexed, patient is having full PIP joint movement. This is known as a positive bundle test, and it shows the intrinsic muscle tightness. Intrinsics may be introsei on lumbricals. So lumbricals, as we all know, they inserts from the radial side of the joint. So we test the bundle test in both radial and ulnar deviation. If the bundle test is more tight on the ulnar deviation, then it is the lumbrical tightness. And when it is a symmetrical tightness, the introsei is the cause. So then we will assess the extrinsic tightness. Extrinsic tightness, for this example, this baby, she is flexing the wrist to get finger extended. So flexors are tight. When wrist is dorsiflex, she is not able to extend the fingers. Extrinsic tightness may be due to extensor. This man, he presented with decreased range of movement at the MP joints. You can see the decreased MP joint movement at the index and middle, and slightly at the ring, and little finger is okay. And there is suture reaction at the dorsum of the hand. When we explored, so this is example of the extensor tendon tightness. We explored the extensor tendon were found adherent. So after evolution, we have assessed the cause, then we have to go for the treatment part. And most of the time, this treatment is non-operative first. We will understand the principle with this example. This 25-year-old male operated elsewhere, some vascular repair of radial and ulnar artery, and tendon was also repaired. And patient was referred to me for the nerve repair. And on the examination, he had stiff hand, no finger movement, and he was a lot of agony. With this condition, no movement at all at 1 month duration. So first we applied this static splint, anti-edema measures were taken care, and then we used when some movements occurred, then started some ADL, some range of movement activity, and low load stretch were applied. And patients, most important, patients were reassured because he was in too much agony about the future of his hand. Then we started getting some range of movement. And this is example of serial splitting. Although this is not the same patient, patient was having flexion deformity, and gradually it is straightened. And ultimately, this is from about 90-degree flexion to straight PIP joint were achieved. So serial static splint gets tissue at its maximum excursion, and next stage we get more excursion. So now the same patient presented with this stage, and now he is having some range of movement. Now we can plan for his nerve surgery. So sometimes we have to use dynamic splints. Dynamic splints may assist the flexor, so known as flexor assist, or may assist the extensor, so it may be extensor assist. We understand with this example, this patient humerus was fixed and he had radial nerve palsy. So this, as in the previous talk by Dr. Praveen, he told that the dynamic splints, they are important cause for MP joint extension because they keep MP joint in extension. So patient presented with loss of movement at the MP joint. So patient was having some responding to manual stretching, and then we started using this flexor assist. So there is continuous traction at the MP joint, and then we were able to achieve the flexion movement. Same principle can be applied when you need extensor assist. Serial casting is necessary when there is severe contracture. We will understand with this example. This patient had forearm fracture, then tight bandage were applied, and he presented with this grotesque deformity. Initially, we fixed with the straighten the forearm. Now there is tight contracture around the wrist. So this was the condition. So now it is very difficult to manage with the splint. So serial casting can be used. So gradually we corrected the wrist. Once wrist we are able to achieve wrist neutral, then MP joint is blocked, and started working on the fingers with the cotton. Soft padding is required because these patients have sensory problems also in the VIC. And once it is fully corrected, then we can start using wrist splints. And then finally this condition is, so this condition can be achieved with the serial casting. So surgical release is required when there is normal or relatively normal articular surface of the joint is there, joint motors are intact, and all non-operative modality has been correctly applied and adjusted. And finally, the diligent, educated, and compliant patient is the most important thing, because if it is post-operative therapy program is not followed, the recurrence of contracture is a certainty. So I will give some example. This 48-year female presented after 1 year. She had some minor injury around the PIP joint, but she is not able to extend PIP joint. She presented with about 90 degree of flexion deformity at PIP joint. We initially tried with serial casting and then sprinting, but it was so rigid, not able to achieve any movement, and patient was so keen to get corrected. So when we opened, there was a thick fibrosis around the flexor pulley system. We able to, when these are released, we are able to achieve some extension, but ultimately volar plate is released, and you can see we are able to achieve this full extension. But gradually mobilization was started, but within 1.5 months, 20 degree flexion contracture was achieved. But we have to satisfy at this point, because this C has achieved from non-functional range to functional range. So I will conclude my talk that evaluation of cause of stiffness is utmost necessary. Conservative treatment is the main modality and successful in most of the situation. Surgery should be opted when non-operative treatment is exhausted. Diligent, educated, and compliant patient is the prerequisite for any surgery. Surgeons should be well aware of rehabilitation with good coordination with competent physiotherapist is requirement. I should be thankful to organizer for the opportunity.
Okay, thank you, Amit. That was a very nice talk. Due to lack of time, we will not take any questions, and I will hand over to Parag for video session. Over to you, Parag.
Yeah, I welcome Dr. Anil Bhatt to share his views and to share a video on carpal tunnel release. Thank you, Dr. Anil.
Thanks, Parag. Am I audible?
Yes, very well.
Okay. I'll straight away go to the video. It's basically, I'll be showing the open carpal tunnel release. Amit had asked me to show only the open carpal tunnel release here. So this is the basic incision. This is the thenar crease here. And for all complications to be avoided, the most important thing is to be keeping ulnar to this thenar crease, about 6 to 7 millimeters here, ulnar to the thenar crease. So everything, if you stay at this level along the border of the ring finger here, the radial border, I think we can avoid a lot of complications. So this is where the Kaplan's lines will basically dissect, and this is the horizontal line here along the wrist crease here, thumb crease here. And then even during surgery, if I just, you get this ring finger here, that is the distal end here. So you should not be crossing that area and try to keep as much as possible in this direction. The carpal tunnel generally about 2.5 to 2.8 centimeters in length. So most of your incision should be only that. In case you want to extend, you need to go across at an angle at the wrist so that you don't cause any kind of a scarring at this point. Now, open carpal tunnel release can be two types. One is you can use the entire length of this in the palm, or you can use a mini incision. So I would insist that in the beginning, when people are doing this, they can use the entire incision and see the structures quite well, and then probably later go on to the mini incision of about just 1 to 1.5 centimeters. But this 2 to 2.5 centimeters length can be used most of the times to visualize the nerve nicely and do a good job so that we don't injure any of these structures. So that is the basic extent of the incision. And once you do that, what you see is obviously the palmar aponeurosis coming in once the subcutaneous fascia tissue is released. And below that would be your the transverse carpal ligament. So these are the superficial fibers of the aponeurosis itself here. And I'm not extending my incision beyond this crease here at this point. And once you do that, clean up the whole area. These are the fibers of the aponeurosis here. And then start dissecting, or rather teasing out all these fibers so that you go towards the transverse carpal ligament. And sometimes you would see a small amount of muscle fibers here. Sometimes these are these actually palmaris brevis muscle here. And you would see that sometimes the muscle can be quite thick actually, or sometimes it could be just a few fibers of these palmaris brevis. I'm staying here in the proximal aspect because the dissection should start from the proximal aspect and then go towards the distal side, not the reverse way. So this is just below the muzzle here is the transverse carpal ligament. And you make a small cut there to see this nerve here. You can see the change of the color there, and the nerve pops out at this point. So that's a small incision you need to make. Be very careful there. The moment you make that incision or open, then the entire dissection should be based on this protecting the nerve through and through with any of these elevators or a kind of this is a McDonald's retractor I'm using here, and everything has to happen over this. So throughout the procedure, you need to protect the nerve and not directly use your knife here. I never use 11 number knife. I always use a 15 number knife for this. So through and through, so keep taking it out and repositioning this, because distally the nerve becomes more thinner and flatter. And so you need to reposition it as you go towards the distal aspect. The distal aspect of the transverse carpal ligament is quite thinned out. It merges onto the fascia here. So it can be very thinned out. It may not be a very thick edge here always. So be careful with that. Once you start seeing the fat coming in, that means the nerve is branching out near that area. And that is where you need to stop your dissection and make sure that you see the nerve nicely, retract the nerve. And if at all there is, so that is the thick edges of the transverse carpal ligament, both sides, which is cut now. And you need to release the deep fascia, the forearm fascia from this side. So you just have to palmar flex the wrist about 30 degrees and go in there, and under vision, you just release that. You always get a giveaway feeling here. Retract the nerve gently onto whichever side it is easy. So basically, I want to see if there's anything else here. Sometimes the nerve, the digital branch of the thumb can be in a very separate compartment. Patients can have deep aching pain in this. So sometimes that has to be released. So check on the tendons, see for any synovial thickening like this. Sometimes this patient was a case of rheumatoid arthritis. That's why we did an open release. Otherwise, I routinely do an endoscopic carpal tunnel release. And always check the floor of the tunnel and make sure that you don't have any surprises. There could be ganglions here or any of these anomalous structures. So always check that. Now, if you want to extend the incision, as I said, always go crisscross at an angle here. Don't go straight, which will cause very bad scarring at the wrist crease. And this patient, as I said, was a patient of rheumatoid arthritis, and we wanted to do a synovectomy and also send it for biopsy. So we just had to extend this in this manner. And we go towards the forearm here, and then, remove this. So here your palmar-cutaneous branch would come on the radial side. You don't really look for it, but you need to be careful if you're dissecting at this area. So usually it's on the radial side. So there is a nerve. So if you see, this is the thickening of the nerve. So this is the flattening here. This is the broad nerve. This is what the actual picture will be in most of the very bad old carpal tunnel compressions. The nerve is on the side here. This is all tenosynovium, the synovial hypertrophy over the tendons. So we wanted to do a timed tenosynovectomy of all these tendons here. The nerve is always retracted to one side, and your assistant full-time holds onto it. And so tendon by tendon. So you have the FPL, then you have the flexor superficialis, digitorum superficialis tendon superficially, and then you have the FDP below. So each of these tendons you pick up, and then you can do a thorough job. Synovectomy in rheumatoid patients actually reduces the load of inflammatory tissue, and that is very, very important for their pain relief also. And it's a very easy way to reduce the load for these patients. And sometimes if there is not a clinical diagnosis and you have a lot of these synovium, you might have to send it for biopsy. Sometimes it could be tuberculosis and other kind of granulomatous conditions. So meticulously remove all these things, all the synovium there, and then check on each of these and make sure that you're not damaged any of these. And sometimes there could be anomalous tendons, anomalous muscles, the nerve. So many things can happen here. The nerve could be bifid median nerve. It could be branching very proximally or very distally. And then there could be interconnections between the ulnar nerve and median nerve. So there could be so many kind of anomalous things which can happen. And so this is the FDP portion of the carpal tunnel. So you have 9 tendons and 1 nerve. So you need to make sure that all of these have been checked thoroughly. Okay, and that's the FPL there. And that's the lumbrical there. And sometimes the lumbricals can be originating very proximally here. And that is the floor of the tunnel itself. So at the end of it, you need to check the floor of the tunnel and make sure you don't have any kind of swellings or any of these. And the most important thing is this first stitch where you do an apical stitch here so that you get the wrist crease back for the patient. That's very, very important. So you go through the skin here, go to the subcutaneous tissue here, and come out of the skin here at this point, and make sure that this wrist crease is nicely formed where your line is there. That apical stitch is very, very important for you to get a nice wrist crease back for this patient. And that's how you end this procedure here. And then we usually sometimes immobilize for a week with a slab and then start mobilizing these patients quite early. Endoscopic release, again, we immobilize quite fast. And my main reason for doing an endoscopic release is basically that there is absolutely no scar in the palm. The incision is basically in the distal part of the wrist crease, the forearm, and that is one reason I like to do endoscopic. Otherwise, it's always an open release whenever indicated for patients with these kind of synovectomy or any other procedures. Thank you.
Thank you, Dr. Anil. Can I ask a quick question?
Yeah.
How will you treat a pillar pain after surgery? Can you quickly guide us?
Well, after starting endoscopic release, I've never come across any of these things. Pillar pain, again, there's a lot of controversies. Why pillar pain comes? Is it just a scar tenderness, or is it because you cut through the ligament, which has proprioceptive kind of, this nerve endings? So that is what it is. But at the end of the day, you need to make sure that it's not the scar, or it is just a deep pain which the patient has. And always be conservative with this. Never go and do anything more heroic. Be conservative, splint them for some time, 2 to 3 weeks. Scar massage, you can use any of these local contractivex kind of ointments, nice scar massages, and desensitization kind of occupational therapists do that. So these are things which we do for a long term of these patients. At the end of the day, again, if you're in doubt, then please get an ultrasound done and to see if there's anything which we have damaged, right? So any of these anomalous nerves or any palmar-cutaneous branch, have we damaged any of these nerves? That is very important before thinking everything is a pillar pick. So get an ultrasound done, image it and see what is wrong and then come to a conclusion.
Thank you so much. I have a small announcement to make. Due to paucity of time, we are not going to have a distal radius plating video. And I now invite Dr. Praveen Bharadwaj to show us how to do a Quervain's release. Welcome, Dr. Praveen.
Thank you, Parag.
Yeah.
Is it seen? Okay.
Yeah, very well.
Okay. So this is a small video on the release of the first extensor compartment. The diagnosis is the most important part, and we need to make sure that we are dealing with dequerence, not any other side of radial wrist pain. Now the incision is made about a centimeter proximal to the tip of the radial styloid, parallel to the wrist creases. So you radially deviate the wrist and see where the creases are coming, and the incision is made right on the crease. And since the sensory branch of the radial nerve is very subcutaneous, as we see over here, we need to be very careful. The incision should not be very deep. It should go only till the subcutaneous tissue. And then we need to retract the subcutaneous tissue, which will have the nerve. It is important not to go and dissect out the nerve. Let the nerve be in its normal subcutaneous tissue. The first extensor compartment is best to identify just proximal to the extensor retinaculum. And once you see the tendon, you would see the sheath of the first retinaculum. And then you start dividing the extensor retinaculum. You see, this is the thick first extensor retinaculum. And this thickness is very typical, and you will always see in patients with a true dequerence disease. Once we get into the tendon, we can cut the first extensor retinaculum. And you see, as we are cutting the retinaculum, we see that the tendon is popping out. And the tendon can be retrieved out. It is very common to have a separate compartment for the EPB and APL. So this patient, you see, we already released the compartment, but there is still one more separate compartment over here. And the tendon which I have just released is actually the extensor pollicis brevis. And there is a separate compartment in which multiple slips of the abductor pollicis longus are present. So the anatomy of the first extensor compartment is really not what we see in the textbook. It is very variable. And you see over here, there are almost 4 slips of abductor pollicis longus. Hence, we should make sure that the whole compartment is released. And this is done by pulling on the tendons. You see, all these 4 slips are only causing abduction of the thumb. But this slip causes extension of the MCP joint of the thumb. So the operation is not over till you see the extension of the MCP joint of the thumb. And once MCP joint extension is seen, and we have seen that the abductor pollicis longus, all slips are released, then we are sure that the release is complete. We do a subcutaneous closure. And since we are doing operation under a block, you can put a slab for a few days. And usually slab is removed at 3 to 4 days, and the patient is allowed to use the hand completely. So Parag, I have made it really very short because the time also was less.
Yeah.
And I'll be happy to answer if there are some pertinent questions.
Yeah, thank you.
Very crisp, very crisp. Only 2 points for the viewers. First, we learned from Dr. Anil Bhatt that endoscopic carpal tunnel is the future. And the pillar pain conservative treatment is the way to go forward. And from Dr. Praveen's talk, first confirm your diagnosis that Quervain's is the only cause of radial sided wrist pain, and beware of superficial radial nerve. Now I hand over proceedings to Dr. Amit Warade. Thank you both the speakers. Thank you.
Thank you, Parag. Thank you, Amit.
Yeah. Thank you very much. So I will briefly summarize the webinar. First, we had a very excellent talk by Dr. Praveen Bharadwaj on radial nerve palsy, and he has shown different conditions, how to manage radial nerve palsy in these conditions. And he has also highlighted nicely about the investigation part of the problem. Then Bipin has nicely shown how to do different X-rays and what is their significance. Then in a session of fractures, wrist session was already summarized by Dr. Pankaj. And in case of in hand fracture session, Nethe sir has nicely shown us the use of splint and extensor tendon reconstruction. After that, Pankaj sir and Binu sir has nicely elaborated us about the PIP joint, everything, right from the anatomy, mechanism, and how to deal with acute cases, how to deal with chronic cases. And Parag has nicely shown us different varieties of metacarpal fractures, how to fix them, and different methods of fixation. And Amit has nicely shown us how to deal with the stiffness of the hand and what are the precautions we should take. So I thank you everyone. So and of course excellent videos by Dr. Praveen and Anil Bhatt sir. So now I will give vote of thanks. I am very thankful to all the respected faculty and viewers for attending this program and taking out time from their other commitments. And I'm also thankful to Ortho TV, Dr. Neeraj Bijlani and Ashok Sham for giving valuable support. They are behind the screens, but they are the main partner on this event. And I will also I also want to thank Dr. Pankaj Ahire because we cannot, due to lack of time, we cannot accommodate his video of distal radius plating. And also I like to thank Pankaj, Dr. Pankaj and Parag for moderation of the session. And thank you very much. Thank you very much for your active participation. Thank you all. Yeah, very good night.
Amit, I'm happy to keep my secrets.
Okay, sir.
Thank you, Amit, for a wonderful webinar. Thanks, everybody.
Yeah, the latest call is 2,600.
Fantastic.
2,400 people are still watching.
Are we offline now?
No, we are going offline now. Okay. Thank you very much. Thank you for the basic hand surgery webinar.
Yeah. Thank you.
Thank you, Dr.
Now we are